So welcome to the 7th annual Montreal Oscillometry Summer Seminar. And this year we've changed things up a little bit. As I've said in the previous seminars online, it was different and the auditorium remains empty. This time it was double booked. So we've relocated to the McIntyre Medical Building, but that's another story. During the virtual years of 2020 to 2022, we made lemons, as I said, made lemonades rather out of lemon. And we really had a reach that we would not have obtained in person. So going virtual had its benefits. I don't think we will be this many attending in person, but virtually we may attend it, we'll see. But to motivate people who are attending virtually to attend in person next year, this is the current venue. We have the Montreal skyline on the upper right with the round McIntyre Medical Building in the foreground, and you see that in the lower left, and that's where we are now. And then we'll have a 2-minute walk over to the Postgraduate Student Society Thompson House, where we will have drinks on this outdoor terrace, weather permitting, and then a sit-down dinner in the ballroom. And that terrace looks over the lower campus of McGill University, which you see in the upper left picture. So the geography is just as such. It's quickly a quick walk, rather, 2 blocks and down to reach the Thompson House supper. So we'll send you pictures tomorrow to let you know how that went. Just to remind you, the recordings of the previous seminars are available, and we are recording this seminar also for posting on the Respiratory Effectiveness Group website. So thank you, REG. And a major thank you to our corporate supporters who have made this event possible, both all of the coffees and the lunches, as well as the networking cocktail and supper that we'll be holding at Thompson House. And also, it takes a team to put together a program like this. And so my 4 medical students, Misha, Paolo, Luis, and Roger, thank you guys very much. The team from the Meekins who are helping register you. So you've met Inga and Jacqueline on the way in. And Dabisha from the Faculty of Medicine, as well as Evelyn and Carolina, who've been handling the accounts on behalf of the RI, interfacing with industry and their donations. So to go back to why we are here, it's been well over 70 years since the conception and the development of oscillometry. And I'm happy to tell you that finally, amongst clinicians, we are seeing traction. And I use this example, and I'm paraphrasing because the recordings aren't yet available, but at the COPD Clinical Year in Review at this year's ATS, Stephanie Christensen said, "It is becoming increasingly apparent that spirometry does not capture the full extent of COPD, and that we should be using alternatives such as oscillometry." So with that, I'm going to welcome to the seminar. We've got a great program lined up. We have 24 presentations, 26 faculty. We are 59 institutions from 5 continents, and that breaks down into 40 universities and hospitals and 19 corporations. So with that, I'm going to end my introduction. I've stolen 5 minutes, but only 4, it turns out. So by coffee, we'll be caught up because kindly Jeff and the following speakers will have donated 1 minute of their talk. So Jeff, the podium is yours, and we look forward to your talk. And I'll let you introduce and tell the, well, no, I'll say it here. Better than plethysmography, tracking TLC in patients using oscillometry. So thank you, Jeff. The podium's yours.
Thank you, Ron. Can you stop sharing your screen so I can start?
Done.
Okay. Almost there. Hold on.
You can see your screen. You can see your
Okay.
Presentation mode. Thank you.
Okay. Ron, thank you so much for organizing this meeting. It's unbelievable. We're in the 7th year already. And I also like to thank the sponsors, and I'm honored to be here and speaking. Sorry, I can't be there in person. Yeah, so I'm going to talk about tracking TLC in patients using oscillometry. I'm going to start with the credits at the beginning. Many of you know Ken Berger. He played a big role in this study. Ori Adam did a lot of the early work and really deserves the lion's share of the credit. Dave Kaminsky was a part of this project, as was Robert Brown at MGH and Julian Solway, who is here virtually. So I also want to say there's a disclosure. This study was supported by Pulm One Advanced Medical Devices, and several of us have financial interest in that company. So here's the standard thing that we teach first year medical students about lung volumes: tidal volume, inspiratory capacity, vital capacity, and so on. There are absolute lung volumes, and then there are differential lung volumes. Differential lung volumes are things like tidal volume, inspiratory capacity, and so on. And those can be measured easily with a spirometer, with spirometry. But there are other volumes that cannot be measured with spirometry. For example, functional residual capacity, residual volume, total lung capacity. These are measured relative to zero, to absolute zero. And the problem, of course, is the zero volume, lung volume, is not physiologically attainable. So how do you measure these absolute lung volumes? They're fundamental. We need to know them. Well, there's several ways. One is using a gas dilution, helium dilution or nitrogen washout, but there are gas mixing issues with those techniques. There's a chest X-ray or CT, and the problem there is the radiation exposure. The whole body plethysmography, actually, Ron flashed this paper just a minute ago from Arthur Du Bois in 1956. This has become the gold standard for determining TLC and absolute lung volumes, but it's for those of you who use the technique, it's expensive, it's a big box, and it's difficult to maintain and operate. And all of these are technically demanding, and they all incur appreciable measurement variability, which I'm going to talk to a little bit. And none of them at all are suitable for a physician's office or a small clinic. So the question is there some other way to measure absolute lung volumes? And I'm going to show you data to try to convince you that the answer is yes. So we call it the mini box TLC, and here's the mini box. You can see it at the left with a patient and a physician. That's the device that we developed, and the guts of the device. It has a dead space of 70 ml, which is comparable to plethysmography. Here's the guts of the device. It basically has a container filled with air, about 16 liters. Nothing magical about that number, but 16 liters. Here, the patient sits here, and it's a flow to the mouth and the mouthpiece. We have a flow meter here, a hot wire flow meter, and then a valve. When the valve is open, the patient is breathing from the room, easily back and forth to the room. But when this valve closes, the patient is making respiratory efforts against the compliance of this trapped gas in the container. So basically, that's the apparatus. The question is, how does it work, and how well does it work in terms of obtaining absolute lung volumes? So here's kind of a schematic in the upper left. Here's that chamber, 16-liter chamber. Here's lung volume. And when the valve is closed, the patient is making a respiratory effort against this chamber, and there will be some volume change there as well due to gas compressibility. So the way the protocol works is, so here's showing lung volume. Here's the patient doing quiet tidal breathing. Then at the end, an inspiratory capacity to TLC, and then an expiration to RV. But where each of these circles are is when the valve closes. It's a closure of 70 milliseconds. And during that short time, the patient's making inspiratory efforts against that chamber compliance. So here's actually showing the flow signal. This is the flow while the valve is open. The valve closes and the flow decreases, but it doesn't decrease to zero. And then 70 milliseconds later, the valve reopens. Okay, so that's a typical mini box flow interruption event. And basically, that's oscillometry, right? The flow interruption technique has been around for decades. Jason Bates has done a lot about flow interruption. This is flow interruption. It's equivalent in many ways to oscillometry. In fact, it's just in the Fourier domain. So here's our thinking. We want to get the TLC as determined by this mini box technique. So if we take on the left-hand side of this equation TLC is determined by mini box relative to the chamber compliance. We reasoned that that must be a function of the flow ratio before and after closure. Alpha is the ratio of specific heats in the container. R is some empirical parameter having to do with the impedance of the tubing, and spirometry data. And again, that's the oscillometry part of this. When we first started this project, we tried to determine the TLC using a mechanistic approach, or the mechanics of the lung, Boyle's law, so on and so forth. Turns out it fails. And other people before us, back in, I think, the 80s, there's a literature of people who tried to determine TLC from oscillometry, and they weren't able to do it, basically because gas is so stiff. It's just very, very hard to determine what the gas volume is in the presence of such a compliant lung. So we decided instead to take a statistical approach to this problem. Nothing to do with mechanism, totally statistical. And we were inspired by what's going on in artificial intelligence. And when we started this, artificial intelligence isn't where it is today. It was much more primitive. We're not using artificial intelligence per se, but we are in the same spirit of using a statistical approach. So here's what we did. In a training set, we took a population of 434 qualified volunteers, and we measured TLC in the conventional manner using body plethysmography. Then in a test set, we looked at a heterogeneous population of 266 qualified volunteers, and this was done at 5 different centers using many different kinds of body plethysmographs. And we determined TLC in the conventional manner, again, using body plethysmography. In the same volunteers, we measured conventional spirometry and flow interruption transients using the mini box. We then used a statistical algorithm. Some of you may know, it's very well known, called the lasso technique. And actually, I have a little note here. Lasso is basically an extension of multiple linear regression, where you wind up forcing many of the parameters that contribute least to 0, and you try to get a much simplified set. So we used lasso to find the strongest set of statistical predictors of what the plethysmograph would have said. So we're trying to estimate plethysmographic TLC. We then validated this approach using something called n-fold cross-validation. And finally, we evaluated the statistical model of TLC mini box against TLC pleth in a prospective heterogeneous cohort. So this is actually a simpler approach than modern AI, but like AI, actually, I'm going to try to show you that this works. We actually don't know why it works, but it works. Okay, the body plethysmography, this was done at 5 centers. Just for example, at University of Vermont with David Kaminsky, they used an MGC diagnostic, and so on at the 5 other centers, and all centers use methods that were conform to ATS-ERS guidelines. So here's the basic result. On the y-axis is the TLC determined by mini box, by the statistical prediction. And on the y-axis, I think I said x-axis. X-axis, I'm sorry, TLC mini box. Y-axis is the actual plethysmographic determination. And you can see a pretty good correlation between the two. This is what's called the Bland-Altman plot. So here we're looking at the difference between plethysmographic and mini box TLC determinations. That's on the y-axis. On the x-axis is basically lung size, the sum of the two divided by 2. And you can see the average value is very close to 0. There's no systematic bias with lung size, and you can see the variability from subject to subject. So let me dig a little deeper into this. We looked at, one of the first things we looked at is day-to-day variability in the same subject. So here, for example, this is using plethysmography, body plethysmography, on the first day and on the second day in the same subjects. And if you actually normalize those to being unity on the first day you can get the fractional change on the second stage. So this is just the run-to-run or the day-to-day variability in these subjects. And the coefficient of variation with plethysmography we found is about 5%, which is typical for people who run well-organized plethysmography labs. We did the same thing with the mini box. And interestingly, what we found in the mini box is the day-to-day variability was less. It's about half of what we found from the plethysmograph. We have no idea why this is, but this is a repeatable finding that the variability in the same subjects in day-to-day is smaller using the mini box technique. But again, we don't know why. But what this does show is that this technique has potential for improved resolution of following patients in a longitudinal fashion. It gives better resolution. Again, here are those same data. I'm going to show you what happens if you actually separate out healthy subjects from obstructed patients from restricted patients. So here, this is for obstructed patients, and they're color-coded for mild, moderate, and severe disease. And you can see the Bland-Altman plot, similar to the population as a whole. And again, the correlation on the right between plethysmographic and mini box. Here's for restricted patients, again, much the same story. And if you look at them all together, so upper left, all subjects, upper right, healthy, lower left, obstructed, and lower right, restrictive. So we get pretty good correspondence in all those situations. We looked at the literature to see how variable the standard methods are. So at the top here is for helium dilution, middle CT, nitrogen washout, and mini box. And this is the normalized standard deviation. So we're looking at the variability. And here's the author of each of these different studies in the literature. This is the number of subjects. They go from as little as 20 to as many as 434 in our own study. And here's the plethysmographic devices that were used. And what you can see here is that mini box shown on the right is at least comparable to or smaller than the variability with helium or CT or nitrogen washout. So mini box gives a similar or smaller variability. Here's another way to look at similar data. Here's again the Bland-Altman plot. So it's the difference between plethysmography and mini box on the y-axis and lung size on the x-axis. These are data collected by Carl O'Donnell, published back in 2009, more than a dozen years ago, looking at plethysmography versus CT. And you can see that actually the variability there is bigger than in regard to the mini box. And here's plethysmography versus helium dilution. And again, you see a lot of variability. And interestingly, I want to point out that there's a mean value here that's close to zero. The difference here is about 50 ml, whereas plethysmography versus CT, the difference is about 700 ml. And plethysmography versus helium dilution, again, it's almost 700 ml. It's well known from the work of Bob Brown that plethysmography overestimates lung volumes because pressure at the mouth does not accurately reflect pressure in the alveolar space upon which plethysmography is based. So we conclude from this that the TLC of the mini box corresponds to the TLC plethysmography at least as closely as CT or helium dilution. So basically that's the story. What we have yet to do, and is not yet done, is to use the statistical approach in pediatric populations where it'd be very interesting to track lung growth, or in geriatric populations. So we don't have the statistical database to do those yet. So that's something waiting to be done. The variability of mini box TLC is it tracks a TLC of the plethysmograph at least as closely as CT or helium dilution. The repeatability seems to be better, and therefore may be better in terms of longitudinal follow-up. So our conclusion is that the mini box may be a reasonable surrogate for body plethysmography, certainly smaller, much less expensive, and much easier to use and easier on the patient. Measuring RV by, or any of the absolute volumes by plethysmography it's complicated for those of you who've done it. It's expensive, and it previously had been accessible only at major medical centers. But now with the mini box DLC, it would be accessible in any small clinical practice. So that's my story, and I'm happy to take any questions.
Question. Can you hear me okay?
Yes.
Yeah. Thank you
Hey,
very much.
Jeff.
There you go.
Yeah, Jeff, that was a really good talk, very clear. And I've wondered about that device, and you've explained it very well. Just one question. When you were talking about the studies you did on all those patients, you called them qualified patients. I wasn't quite sure what that meant. And I guess my question is, were they people with normal lung function? And if so, how would this work on people without normal lung function?
Yeah, well, actually, we looked at three groups, healthy individuals and people with documented obstructive disease and documented restrictive disease by the physicians in the study. I mean, I'm not one of the physicians, but people like David Kaminsky and so on, these people had documented diagnoses.
I see. So it panned out with them too. Very
Yeah, surprisingly, the statistics somehow was able to, there's enough information to be able to parse those out.
All right, great, thanks.
Yeah.
Jeff, Maxim.
Thanks, Ron. Thanks, Jeff. Very nicely presented. I'm curious about what we know it's doing. So it uses the lasso technique, and it's trained on many, many individuals.
Right.
And the lasso technique still gets a set of parameters that it decides are the important ones from the waveforms that you collected. These are interrupter waveforms, and I guess you're using the waveforms as raw data.
Right.
Almost like the principal component analysis, a lot like that.
Right.
And investigators have tried to use that to map those coefficients that you get from the lasso to mechanistic measurable parameters, the things that you're seeing in the interrupter response. It could be the time to decay or all these things. Have you got any sense of what are the primary components from the lasso mapping to in the interrupter response? What's the key thing?
Yeah, we looked, I can't remember the number. We looked at 20 or 30 different metrics and boiled it down to just a handful. The one that from the interruption, the one that was the most predictive was the flow ratio before and just after flow interruption. But again, there's other data that goes into this, like spirometry and some anthropomorphic data. So somehow the statistic parses all that out, but mechanistically, we don't have a clue as to actually why it works as well as it does.
A quick follow-up, how much of it is the mini box and how much is all the other measures that are done complementary at the time?
It turns out that's proprietary, and I can't tell you. That's how I get around all the tough questions.
Okay, I'll address the elephant in the room. We had Murray Beaton from Novus, who's one of our contributors, saying, "Hey, why are we promoting commercial stuff?" So I'll just address it.
Oh,
listen, Murray. We're sort of on the cutting edge here, and a number of us will have interests in various technologies, patents or developing, and that's just the nature of the beast when you're at that. So I hope that we can all get around it and share what we can, because at the end of the day, we want to improve patient care, and this is how we have things go forward. I'll take another question from Wayne. Wayne, are you able to turn on the camera so we can see you?
Can you hear me?
We can hear you fine, but we can't see you.
Okay, well, I can start my video too. So Jeff, that was a good talk, but I'm curious about why TLC is, growing up with Saul Permit over many years, he always emphasized the fact that residual volume was probably the most sensitive index of different lung diseases. And I'm wondering if you could calculate from TLC
Oh,
the
right.
valve capacity, obviously residual volume. Did you try to do that and see how
Yeah.
that compared?
Yeah, we did that. It's we settled on TLC. I'm not exactly sure why, but yeah, once you know TLC, then from spirometry you can get everything else. So you can get RV and so on. So yeah, it's implied in all that. The variability can be a little different because it's a smaller number.
Or you're subtracting two numbers then
Yeah,
too.
right. Yeah.
We have Charlie raising his hand for a question, so let Charlie chime in at this point.
Jeff, fascinating talk. In looking at your shutter closure profile,
Mhm.
pressure isn't constant, it's varying a fair bit. What are the technical details, from an operator point of view, kind of quality control? Do you look at those to establish the fact that you're getting decent closure, you're not getting global artifacts, et cetera, et cetera?
Yeah, I mean,
Because as you pointed out correctly, with this graphic approach often doesn't get the right answer because the pressure at the mouth isn't accurate.
Yeah.
But then there's the pressure you actually measure.
Yeah, actually we had measured a variety of pressures and they turned out they weren't terribly informative, like pressure in the chamber and so on. So the last so we wound up throwing those out. In terms of, we did flow interruptions over many breaths, and I don't remember, there was some quality control that we did, but frankly I just don't remember exactly how we did that. It's probably in the paper we published, but I don't recall. I'm not trying to be evasive. I just don't remember.
Okay, well, maybe if you come to dinner with us afterwards, you quickly drive up, it'll come to you and you and Charlie can talk further about this. So Jeff, thank you very, very much. I'm going to move on because we want to leave spots time for the others. So the next talk is going to be using oscillometry to evaluate static lung hyperinflation in patients with severe asthma. So we're going over to a little bit more of a clinical talk. And Ye Han Seo from the National Yang Ming Chao Tung University in Taiwan is going to be giving this talk. However, I think he's a little closer to us. If I remember correctly, Ye Han, you're in California right now, are you not?
Yeah, it's early morning here.
Please introduce yourself and we'll look forward to your talk.
Thank you, Ron. Good morning, everyone. My name is Yi Han Shao from Taiwan. I'm a pathologist in Taipei Veteran General Hospital, and I'm now a visiting scholar in UCSF since last December. And it's really a pleasure to having me here to join this meeting. Today, I'm going to share my study titled Using Oscillometry to Evaluate Static Lung Hyperinflation in Patients with Severe Asthma. So let me start from some background introduction. As we know, asthma is characterized by small airway inflammation and remodeling. And in a recent study from the Atlantis cohort, they use many lung physiology variables to measure small airway dysfunction. And you can see this figure, the prevalence of small airway dysfunction increase in more severe diseases in asthma. And a study published last year, also from the Atlantis study, they show that there is a increased ordinal score composed of oscillometry parameter could be a predictor of asthma exacerbation. And static lung hyperinflation, as Jeff said, is usually measured by body polysynthetic. It is increased volume of air trapped in the lung because the premature closure of small airway. And recent study that is the data from the SARP, and which showed that the lung hyperinflation is associated with accelerated FEV1 decline and future exacerbation in asthma. And as we know, there is a many limitation of body polysomnography, which is effort dependent, and it is could be challenging for elderly or subject with poor lung function, such as severe asthmatics. So that brings us the idea that could we use the oscillometry to evaluate steady lung hyperinflation in patients with severe asthma. So we are lucky to join the International Severe Asthma Registry a few years ago, and we have already collected over 100 severe asthmatic in our hospital into our Taiwan Severe Asthma Registry. As shown in this figure, the demographic is similar to other countries except Italy and the UK. We have about 72% of uncontrolled GNR step 4 asthma and 27% of GNR step 5 asthma. The table on the right side, as you can see, the annual exacerbation number is 1. They are not really a frequent exacerbator, but they most of them had a significant airflow limitation defined by FEV1-VC ratio less than 0.7. And they do have increased RV-TOC ratio according to the body polysomnography. And we in our hospital, we do a lot of impulse oscillometry. We use the Jaeger machine to measure the small airway function by the impulse oscillometry. So we also except the body polysomnography, we also perform IOS for these patients. And it turns out we have in these 107 adult patients with severe asthma, we have 83 patients with static lung hyperinflation defined by body polysomnography. And this is the basic baseline characteristic. As you can see, there's a 77.6% of patients had a steady lung hyperinflation. And this compared to those without steady lung hyperinflation, there are more female, they are had older age, they have more late onset asthma, and they have less atopy. Otherwise, the characteristics are similar in both groups. But if we look into the pulmonary function, including the polysomnography and the impulse oscillometry data, we can see that those subjects with static lung hyperinflation had a poor lung function, including the ratio, FEV1-VC ratio, FEV1, FF25 to 75%, RV-TOC ratio, of course, and more severe small airway dysfunction in the IOS parameter, including the R5 minus 20, FRAS, resonant frequency, X5 or AX. So to achieve our goal, we want to determine whether IOS parameter could predict steady lung hyperinflation. So the first step is to investigate the correlation between RV-TOC and IOS parameter. So as you can see in this figure, there's a poor IOS parameter, including R5 minus 20, X5, resonant frequency, and X were well correlated to the RV-TOC ratio. So we can do the ROC curve analysis to look at their performance. And as you can see, they are both good to, these 4 parameters are good to predict steady lung hyperinflation in our cohort. And especially the X5, the X5 had the best performance to predict steady lung hyperinflation with the area on the curve of more than 0.8. But the next question, we have already collected them since several years ago. And so there are 41 patients who receive add-on biologics and complete 1 year follow-up in our cohort, including Most of them receive omalizumab, and but there are about 1/3 of them receive anti-IL-5 therapy, including the mepolizumab and the benralizumab. And what we are interested with what would change after they received biologic after 1 year, especially in except the symptom improvement, the biomarker improvement, as you can see in this table, and FEV1 improvement after the biologics. What's the change after after they receive biologic and 1 year? But unfortunately, we except the FEV1, we don't see any significant change in other polyphysiography parameter, including the impulsive oscillometry parameter. So I mean, that's weird because we can already see the improvement in FVC, but we don't see any improvement in the small airway function. But if you look at that deeply, we can still find there's about 1/3 of them. There's 13 patients over 41 of them. They actually had improvement of small airway function. We define that by decreasing both airway resistance, which is R5 minus 20, and the airway reactance, which is AX, at 1 year follow-up. And as you can see, this table compared to those had worsened small airway function, those severe asthmatic with improved small airway function after biologics had more female and actually had poor pulmonary function, including FEV1-FVC ratio, FEV1, FF25 to 75%, and they had increased RVTOC ratio and worsened iOS parameter at baseline. And if you look at the change after 1 year biologics, you can see there's a significant improvement in impulsive oscillometry. That is the definition. But you can also see there's a significant improvement of FEV1-FVC ratio, FEV1, FF25 to 75%. However, we don't see significant improvement in ACT score, which is the symptom, and RVTOC ratio. However, if you look at the number, they are numerically larger than those with worse small airway dysfunction. That would be probably the small number of our current cohort, or maybe we should follow them for a longer time to see what is the change. Okay, so the summary of my study is that nearly 80% of patients with severe asthma in our study had static lung hyperinflation measured by body polysomnography. There have more female elderly, more late onset asthma, less atopy, and poor pulmonary function, including worse small airway function measured by impulsive oscillometry compared to those without steady lung hyperinflation. And the result from our study shows that iOS parameter were well correlated with the RVTOC. And so the RC curve analysis shows that they are all good to predict steady lung hyperinflation in those severe asthmatic. And among them, the X5 had the best performance with AOC more than 0.5. And the last thing in our cohort is that we don't see significant change in RVTOC or iOS parameter after 1 year biologic treatment. However, there are still 1/3 of them has significant improvement in small airway function. They are more female for lung function and iOS parameter at baseline, had better response in FEV1, FVC, and FEV1, FF25 to 75%, improvement after treatment, but we don't see a difference in ACT score or RV-TLC, although they had a numerically larger than those without small airway function improvement. That would be probably we should need more numbers of patients and maybe longer follow-up to discover what happened to them. Okay, with that, I'll appreciate your attention and I'm ready to take any question. Thank you.
Okay, Ian, great. Stop sharing your screen and we'll put the gallery view up. That was a wonderful talk. I see there's some questions from the audience. Just before that, my one comment is amongst my COPD patients, I get numbers very similar, correlating the lung volumes, particularly the RV and the RV-TLC. In roughly 300 people, ours of about 0.6. I don't know if other people in the room want to share what they see. And likewise, the response physiologically to biologics after time, I have only 11 in my practice on it, is quite variable. Some we have, both spirometry and oscillometry, changing, others not. But I see, unlike you, the ACQ scores changing quite a bit. I mean, their symptom control is impressive. And I know there's a number of industry members who are watching very carefully to see what oscillometry might bring to the table for following biologics. So those are my comments. I saw that Laura had her hand up from Mexico City asking a question. Laura Gauchia, if you're able to turn on your mic and show us your face on the video. Are you there?
Yes, hi.
Hi, Laura.
I'm very happy to see you from Mexico. So I have a question about, did you make any correlation about how these patients respond to the bronchodilator, just to analyze if it is reactance or resistance, the variable that changed the most in these patients? Because, by spirometry, if the bigger change is with FEBC in asthmatics, they are probably having some air trapping. So in these patients, you show that X5 was the main variable that you found, but I wonder if you make any correlation with the bronchodilator response.
But unfortunately, we don't. I don't do the analysis, but I can provide you the data if you want. But the result from our study shows that the change after 1 year follow-up is mainly in FEV1 instead of the FVC. Yeah, and according to our cohort, there are more than 70% of them received a triple therapy, including LABA/LAMA and ICS. Yeah, I can do the analysis and send it to you.
Thank you.
Yeah.
Jules, welcome. Nice to see you down in Philadelphia.
Hi, nice to see you. Thanks for allowing me to speak. Great talk so far. That was a wonderful talk. I have a question for you. Have you compared oscillometry to spirometry in terms of being able to predict static lung hyperinflation? Have you done similar receiver operator curves for just plain old spirometry, like FEV1 VC or FEV1 alone, in terms of predicting hyperinflation?
Yeah, that would be interesting. But the aim of our study is to use the impulse oscillometry, which is a more effortless way for a more friendly way for our severe asthmatic patient to be a surrogate to evaluate the steady lung hyperinflation. So we don't do the same RC curve analysis with FEV or IVC, but
I believe you have all the data where you could do that if you were.
Yeah, I can do that.
Really,
Yes.
yeah, very interesting. Thank you.
Thank you.
Hang Lee, Chris Wu, you have your hand up. Please turn on your video and introduce yourself to the group and ask a question.
Okay. Thank you, Dr. Danaran, and thank you, Ian, for your great presentation. I'm Jianwei Wu. I'm from Toronto. I'm a PhD student. So I'm just wondering which reference equations you use for in your plasmography. It's like GLI or the other equations.
I believe it is the GOI formula in our in that body polysystemography.
Okay, thank you. So have you tried to use upper limit of normal to define the static hyperinflation?
No, we I believe we don't. I do not. No.
Okay. Okay. So yeah, maybe you
That
try
would
that.
be I can explain that more because the we are still we're trying to revise our upper limit of normal and lower limit of normal of the GI population in Taiwan because we use the formula based on like decades ago. So there's a significant like body height, body weight change in this year in Taiwan. And so we are trying to revise that formula for the GI the formula. Yes.
Yihan, I'll let you field one more question from Ivan Cheres. Ivan, introduce yourself to Yihan and go ahead and ask your question, but video on, please.
Thank you very much. Good morning for all. It's a good lecture. Congratulations.
Thank you.
I want to do a practical question. How many minutes do you recommend to wait after you use bronchodilator when you use oscillometry?
Say it again. Well, what is the after bronchodilator?
When you, for example, in spirometry, you wait 15 minutes to repeat the test after bronchodilator.
Yes.
When you use oscillometry, how many minutes do you wait?
How many means?
No, minutes.
Oh, minutes.
Minutes.
Yeah, I mean, it's this we also wait for 15 to 20 minutes after the bronchodilator inhalation, but we do the oscillometry first before the spirometry. Yeah.
Okay, thank you.
Show of hands from the room who agree with that. 15 minutes between bronchodilator and oscillometry, always before spirometry. Okay, so it sounds like we're doing the same thing in many parts of the world. So thanks a lot, Yihan. We'll let you fade into the background and watch the rest of the seminar, but feel free to pop in and ask questions, and look forward to catching up with you in person at the next meeting.
Thank you.
Okay, so we now have Silpa Kreft, who's coming from the University of Colorado, and we're going to change pace to having a live talk. So Silpa, we met down at ATS. Welcome to Montreal, and I'll let Paolo get your talk loaded on here, and then we'll take off and listen to what you have to say.
So while you were all like just waiting for the talk to go up, I reached out to Ron to actually ask him to help with some programming for the American Thoracic Society conference because of expertise in oscillometry. And I consider myself a novice and someone who's interested in this technique. So I think that I will present to you some of how we're thinking about using some data. So this is a little bit data light, but we are interested in getting some feedback in the application of this in one of the cohorts that I follow at the VA hospital in Colorado. So I'm actually in general pulmonary and critical care physician, but I also subspecialize in occupational lung disease. And I've been interested in non-invasive markers of lung disease. So what I'm going to be talking a little bit about today is comparison of lung clearance index via multiple breath washout, as well as some of the data we have from forced oscillation in coming from a cohort of veterans with deployment-related lung disease, specifically asthma. Okay, perfect. So Before we kind of go any further, these are my disclosures. Our program receives funding from the Veterans Administration and Department of Defense, and we actually also receive some special money from a VA Center of Excellence that's focused on deployment-related lung disease, and some private foundation funding as well. So opinions, interpretations, conclusions, and recommendations are my own and are not necessarily endorsed by the Veterans Affairs or the United States Department of Defense. So I think before getting to a little bit of the oscillometry, I just wanted to give you some background. I think you'll see some parallels in what you may have heard in the literature about the World Trade Center population to the group of patients that I usually see. So over the past 30 years, the United States has deployed over 3.5 million people to Southwest Asia and nearby regions. So I've included a map with some of the countries that I'm talking about when I say Southwest Asia. And exposures, so many people have reported a number of exposures during deployment, like many complex inhalational hazards, not really one defined kind of thing. And I've listed, many of the things that we hear about commonly. And two that have gotten a lot of press are burn pit emissions. So this is trash that's generated by military operations and disposed of and burned. And then also desert dust, particulate matter. And I've listed some of the other things on here too. So with that, I mean, over the past few decades, it's really taken some time, like in terms of the epidemiology, to understand that people may be at risk for respiratory symptoms and diseases. And I've listed that there's really a spectrum from the upper airway to the lower airway of abnormalities that we can see. But the ones that we've really focused on are asthma, and then the nomenclature, we struggle with this when we say small airways disease, bronchiolitis. I think what we're talking about is the distal compartment of the lung, primarily airways, but sometimes even some interstitial abnormalities. For the purpose of this talk, I'll focus a little bit more on asthma. But I have some pictures here on the side where you can see that we see a variety of things on lung biopsy. This is an example of constrictive bronchiolitis, hyperinflation, emphysematous changes, even that are not necessarily present on imaging, and then granulomatous inflammation. In case you're wondering what we may see actually on surgical lung biopsy. So many of our, well, I wouldn't say many of our patients, but some of our patients also have distal lung disease beyond just asthma. And so the data that I'm going to be talking about comes from a cohort study that I've been building at our local VA in Colorado. Our program is called the LEAP study, and really it's a focus on trying to understand what happens to these people over time. So our overall goal was to develop a well-characterized cohort of Southwest Asia deployed veterans with and without lung diseases like asthma and the distal lung disease. So the first aim was to establish the cohort. We have a second aim that's more mechanistic, looking at cellular markers of inflammation. And the data I have today really comes from what we've set up to hopefully be the longitudinal respiratory outcomes. I have data from our baseline study visits, but we are still collecting our longitudinal, or we're still in the middle of our longitudinal visits. So hoping in the future to share some further information, and hopefully you can all guide me in some of the parameters we should be looking at in things like oscillometry. This is our study protocol. So while oscillometry is not a part of that, this is, I think recent studies and just the ease of oscillometry compared to multiple breath washout has made us think about pivoting in the future, or at least adding that to our longitudinal follow-up. So we have a control population, people who are exposed who report no symptoms, and they've gone through a blood draw, they do spirometry. We also add diffusion capacity in smokers. And we have an exposure questionnaire, and we do LCI testing via multiple breath washout. In our symptomatic group, they do essentially the same thing as well. But in our symptomatic group, we actually have some oscillometry data, which we do not currently have in our control group. So this is kind of our progress to date. We've enrolled 182 symptomatic deployers, many with lung disease, and then I have 56 controls. So kind of now like segueing into the lung clearance index and forced oscillation testing, this is the device that we have used. It's the Echomedics instrument from Switzerland for multiple breath washout. We also have an NDD machine that we have not started because we don't know about the comparability. So I think we're going to have to take a look at that. But because we actually share data sets with a cohort of active duty military personnel and some veterans from National Jewish Health. And so we've tended to harmonize our LCI data by using the same instrument. So we have found that while it had, in some of our previous studies, we found that this happened to be more sensitive than a lot of our spirometry markers in detecting abnormalities of these symptomatic patients. Because many, I would say about 70% of our patients would have normal resting PFTs. And so LCI seemed to be promising in that regard, but as many of you probably know, 30 to 60 minutes, it can be finicky. Coaching, I mean, I think our research coordinator at times wants to throw the machine out of the window, And then in terms of oscillometry, we are using a Resmon device right now because some of the other sites that we work with clinically at the VA also use a Resmon FOT system. And so here are sort of the methods just for the data that I'm reporting right now. So this is just a cross-sectional evaluation comparing measurements of LCI and FOT parameters from an ongoing research cohort. Most of what I have is descriptive data, although I am meeting with our biostatistician next week to hopefully look at more parameters. All of our study participants were recruited from our pulmonary clinic between 2020 and 2023, and were diagnosed with deployment-related asthma based on previously published diagnostic criteria. So many of our, I would say nearly 50% of our patients with asthma may have not met, updated ATS criteria for like with bronchodilator response or GINA guidelines for asthma until we did a methacholine challenge. So many of these individuals also have had bronchial challenges. And then LCI was available in all of the patients I'm presenting here. FOT was not available in all because it was not part of our study protocol. So we've kind of used that from a clinical standpoint. We are using asthma control test questionnaires too clinically and also in our research study. We defined, I think somebody was talking about upper limit of normal, an abnormal LCI score as, the average of 2 or 3 tests that was greater than the upper limit of normal. And then for the asthma stuff, well, we have some other parameters. I don't have that data for you today. The total airways resistance or R5 was measured by oscillometry and defined as an R5 greater than the upper limit of normal. We also have X5 that was defined as less than the lower limit of normal. And then I have some of these descriptive statistics. So this is just in a nutshell what we have so far. We found that the LCI index was abnormally increased in 28%, so 16 out of the 57 with deployment-related asthma. And then the average LCI was 8.0, but you can see it's quite, quite a range there. And the FOT was significant for an abnormal R5 in 47. So this was 22 out of 47. So you can see a smaller total N here, and abnormal X5 measurements in over half. The average asthma control test score in our population was 14. We do endotype a lot of our patients. I would say our age range is generally from 30 to 50, even though I don't have these demographics for you. And we are looking at TH2 versus non-TH2, and nearly half of our patients have non-TH2 asthma. So whether that contributes to some of this low ACT score, we're not certain, and this is on treatment. 3 of the 37 study participants with ACT data scores available have an ACT greater than 19. So I think what we've been able to tell from this was that LCI was less frequently abnormal than the R5 and X5 in study participants with DRA. Asthma control is suboptimal in most of our cohort based on our ACT score. And then although correlation was not directly assessed, our study findings may suggest that abnormal oscillometry measurements may correlate with patient-reported symptoms of asthma control. So these are some of our future directions. We'd like to look at longitudinal lung function. I think while I didn't present spirometry data, looking at that, LCI, I think that our research coordinator would like to throw that out completely, and then oscillometry. So these are some of the things we're looking at. I know that there's, commercial interest and things like that, but we're also interested in talking about instruments that are approved for clinical use and getting some of your thoughts about some of that. So this is our team, and happy to take any questions.
Well, Silpa, thank you very much, and you're certainly in the right place. I think you're going to have more suggestions than you might want, and I've encouraged over the networking cocktail and the supper for you guys to please seek out Silpa. I mean, I have off the cuff several suggestions, but I'm not going to take up the time giving them to you. I'll start with Larry.
So thank you very much. That was very interesting, very exciting population. I commiserate with you on LCI, coming from the CF world where looking at LCI and actually trying to look at oscillometry as an alternative.
Oh, yeah.
So actually, so one way we're trying to look at it is sort of cross-hatching where do people fall out? In other words, are we picking up people who say normal spirometry but have normal LCI or FOT, and also similarly comparing the LCI seeing where they fall in. Our hope is that oscillometry is simpler to do, will be as sensitive, not more sensitive. And the funky ones are the ones who have a discrepant LCI and FOT. Haven't figured out what that means yet. But congratulations, that's very interesting.
That's interesting. We got our interest in LCI from our CF group, actually, at National Jewish Health. I think they probably commiserate with you too in terms of the washout, and the difficulty. Our patients do wash out faster. We're a little bit luckier.
The other suggestion is, I'm glad you're using the Westmon device, which will allow you to look at intrabreath. And if you tease out to get rid of the flow dependencies of resistance, for example, you might be surprised at some of the things you're going to see. So reach out to them and work with them.
Okay.
We have a debate whether this is best done at 5 hertz or 10 hertz, but their data can be teased that way, and that would be a major step forward for you, I think.
Okay.
So then you're going to be paying attention to the last block of talks tomorrow, where we're going to be talking about that in detail.
Okay, that's good. Thank you.
There's a question on the screen.
What? Sorry, what's?
There's somebody on the screen.
Oh, well, sorry. Sandeep, wishing you were here in person, Sandeep, but welcome from India. My apologies about our Canadian embassy and their inability to get you the travel visa. Please.
No, thank you, Ron. Silpa, that was a brilliant presentation. Thank you so much. I did not get the feel of what was the sample size of your study. How many subjects did you actually do the study in?
In the study, there are 182 with symptoms and lung disease, and then 55 control. So we still have some data that we haven't looked at. Some people had not been checked off as like asthma or differentiated. So I think in the next couple of weeks, we're hoping to round out that data. I'm sorry that we weren't able to get it to you before.
Anything you found with the area of reactance? Because I think that is probably going to be the most sensitive parameter in oscillometry to find something.
We haven't looked at that yet. That was not something that we could look at previously, like when we were working with Resmon, but I think that has now become FDA approved. So for them to report that.
Yeah, what Silva's
number.
talking about, Sandeep, is they have the tri-frequency, which if you're sick, you're not going to achieve resonance frequency, and therefore you're not going to have a true AX. It's going to be a truncated AX. However, if they've been able to go ahead and get the readouts, they do have the full spectrum up to 37 hertz available, and hopefully actually you captured that data and you can go back in retrospect and get it.
That's like with this kind of update, then we can download that data. So hopefully again in the future.
And Raphael and Robbie, if you're out there, I'm glad to hear that this has gone forward. So thanks for working on that. One more question, David.
Yes. Just to throw a wrench in this, if you're trying to figure out mechanism of disease, I would encourage you to keep the LCI in there, only because even though it's harder to implement, we know that oscillometry is measuring something. We know spirometry is measuring something. We know LCI is measuring something. I happen to think ventilation heterogeneity is probably the primary driving factor in all of these things. And we're looking at them with different sort of snapshots of different instruments. So it might be very complementary to keep the LCI together with the FOT rather than just throw it away.
No, that's the plan. I think right now we're at this place where should we pivot to another instrument like the NDD, which actually is approved like for clinical use too. So we could actually tell our patients something with that, so yeah.
So we need to have a device comparison study between the two to see where we're at with that. Okay, well, we could go on, but we will shift to cocktails for further discussion from Silpa. Thank you very much. We're going to share the screen now with Jason Bates. Let's see, I'm going to stop sharing this screen. And Jason, hopefully you're out there still?
I'm
and
here.
take
Yes,
over.
indeed.
Good. Let me just
Okay.
get through what I have to do here. Stop sharing. And now you've got full control.
Okay.
So Jason is coming from the University of Vermont, for those of you who don't know him, but I think he's a little further south than that. And he's going to talk on insights into asthma of obesity provided by an anatomically based inverse model of lung impedance. So we're continuing in the asthma theme.
Yes, thank you, Ron. Let me just get started here. Can you see that?
Yes.
Okay. Right. Well, I am indeed located physically in Florida, but still at the Larner College of Medicine at the University of Vermont. Let me begin by, once again, as I do every year, as everybody does every year, thank Ron for his enormously important contribution to the field and to the burgeoning field of oscillometry in particular. So with that, what I want to talk about today is a study that I talked a little bit about last year, I think, but it became more mature this year, and we published a paper in the Journal of Applied Physiology earlier on, a few months ago. And it's about obtaining insights into the asthma of obesity by fitting an anatomically based model to the measurements of lung impedance made in obese subjects. First of all, some disclosures. I consult for a couple of companies, and this work was supported by an NIH grant. So my first foray into the asthma of obesity began here, a paper published in 2014. And I got into the game sort of late in the study when my colleagues listed here in the authorship list had collected a bunch of oscillometry data using the iOS system in obese subjects. And, I got involved to try and help them interpret the data. And so, there we go. Just get rid of something here. Okay, and so what you can see in the symbols are real and imaginary parts of impedance in control subjects and asthma subjects. And in both cases, they were very obese, and they were measured pre and post bariatric surgery, about a year after bariatric surgery, when they lost a lot of weight. And I won't go into all the details of the differences, but there are differences in the impedance measurements that we got. Impedance was greater in the asthmatic compared to the non-asthmatic subjects. And in both cases, it was reduced when they lost a large amount of weight. Now, the way we interpreted these data was to fit the following model to it, which is a two-compartment model containing proximal and distal resistances and elastances with a proximal inertance. And that inertance is necessary because we have to account for the fact that there's a finite resonant frequency in the reactance there where it crosses zero. And the curves, the solid lines rather, shown on the right are the fits to those various sets of data. The fits aren't perfect, but they capture most of the sort of key variations with frequency that you see in the real and imaginary parts. And so then, of course, we could look at how the values of the model fit parameters changed between asthma and non-asthma, between pre and post bariatric surgery, and so forth. Long story short, basically nothing really changed except the elastance values. Elastance went up a lot. Well, sorry, I should say it went down a lot following surgery. The resistance and inertance values didn't really change at all. So what it looked like was that the effect of asthma in obese subjects was to increase their lung stiffness or their respiratory system stiffness. And the effect of large weight loss following bariatric surgery was to decrease it. So what I started to get into a couple of years ago was asking whether we could fit an inverse model to impedance that more accurately represents lung anatomy. And in particular, what might this suggest about the asthma of obesity? The idea of doing something like this actually was first suggested, I should say, by Jeff Fredberg a long time ago. I wasn't quite in diapers back then, but some of you were, and I think it was 1978, if I recall. But I don't believe anybody had ever actually done it until recently. And the model that I used is shown schematically here. It's a branching, asymmetrically branching airway tree. And at the end of all the terminal bronchioles, there's an alveolar tissue unit with a constant phase impedance. So this whole thing represents the asymmetric branching airway tree structure of a normal lung with tissue on the end. But it's parameterized by a very small number of free parameters because well, let me tell you what they are. So we have, first of all, the number of airway generations or orders is 25, typical of a human lung. The difference at any point in that tree between the order numbers of the two daughters branching off from any parent is 3. That's the Horsfield delta. We have to have the viscosity of air and the density of air in order to calculate resistances and inertances of every airway branch. The airway length to radius of any segment is assumed to be 6. And so for every single branch in that tree, the ratio of its length to its radius has a value of 6, which is an assumption, but that's pretty typical of an airway tree. Hysterosivity was assumed to be 0.15, and that's necessary for putting in the constant phase model that Zoltan Hantosh introduced many years ago. We also have to take into account the fact that the trachea is longer than all the other airways by a significant factor, which I assumed was 4. So there's a lot of assumption in this, which is necessary because we have to reduce the number of free parameters, the parameters that are going to be estimated when that model is fit to data, to make it as small as possible. And the free parameters are the rate at which airways get smaller as you go down distally into the airway tree. And that's a factor called gamma. So if gamma is 0.5, for example, it means that a daughter, an airway of order n is half as long and half as wide as an airway of order n-1, that type of thing. And that's assumed to be the same throughout the entire airway tree. We have to start with the radius of a trachea, which I call R sub n, n being 25, because the trachea is an airway of order 25. We have to assume an overall respiratory system elastance, H, which is the H parameter in the constant phase model. And that is another parameter that's estimated by the model fit. And we also have to estimate a proximal shunt elastance, because the shunt elastance is always there and it has a pretty major effect on the measurement of impedance, particularly when the airways become constricted. So the name of the game here is to make assumptions for all those fixed parameters, giving them the values that I've listed, and get the model to estimate what the value of those 4 free parameters are by fitting the model to the data. And I'll just mention briefly the fitting process is a bit of a job. It takes a while to fit that model because you have to do it in an iterative manner. But it turns out that it can be done. So here's what the model fits look like. We're showing here the real and imaginary parts of impedance as a function of frequency in 4 groups of subjects: lean controls, lean asthmatics, obese controls, and obese asthmatics. And these data were collected by my colleagues at UVM, most notably, or who were led by Ann Dixon and Dave Kaminsky. And you can see that the obese asthma, for example, has a bigger magnitude reactance, a bigger magnitude of resistance, and so forth. And measurements were made in the same groups post-bronchodilator. Okay, so what do the model parameters look like? Well, first of all, the model, well, you can tell from there that the model fits look pretty good. Those curves go pretty much through the points. If we look at the mean squared residual of the fits, they were not significantly different between the groups, either pre-bronchodilator or post-bronchodilator, and they were pretty small. You know, go back here, the impedance magnitude is, you know, in the digits, +6 to -4. Here we've got mean squared residuals of 0.2, 0.4, something like that. So the fits were pretty good. But what about the estimated parameters? Okay, so we're showing here pre-bronchodilator and post-bronchodilator, either side of the vertical dashed line, for the 4 groups, and they're listed down here: lean control, lean asthmatic, obese control, obese asthmatic. So let's take this RN parameter. This is the radius of the trachea. And it's around about 1, which is pretty typical. And we can see from these whisker plots that there is actually no difference in the tracheal radius estimated from those impedances among the 4 groups, either pre or post bronchodilator. And bronchodilator doesn't even seem to make much of a difference, at least as far as the model fits are concerned. If we look at gamma, which is the ratio or the factor by which airways get smaller as you move distally into the lung, and this has a value of around about 0.82-ish, between 0.82 and 0.84 on average. So in other words, how quickly are the airways getting small as you move distally? That doesn't seem to change either pre or post bronchodilator or between the 4 groups. So if you think about it, this tracheal radius and this gamma factor tell you basically how wide the airways are and how quickly they're getting narrow as you go distally. So for example, if you had distal bronchoconstriction, gamma would be reduced. If you had proximal bronchoconstriction, RN would tend to be reduced. But neither of those things seem to be happening. And if we calculate the terminal radius, the radius of a terminal bronchiole from these parameters here and the structure of the airway tree, that also doesn't seem to be changed. So none of this intervention or differences in groups seems to change the airway structure. So what does change? Well, the bottom line is lung stiffness again, like we found with the original study I got involved with 10 years ago. So if we look at the respiratory system resistance, it's around about 50-ish pre and post bronchodilator for the 2 lean groups. For the obese groups, it starts to increase in the controls and increases quite a lot, statistically significantly in the asthmatics. Bronchodilation seems to reduce that increase a bit, although it's still apparently there. And if you look at the final free parameter, the shunt elastance, there's some suggestion it might be increased a little bit in the obese asthma, but basically there's no change there. So this is where the action is again. It's in the stiffness of the lung. Well, we're measuring the stiffness of the respiratory system, but we presume that any differences we see are due to predominantly changes in the stiffness of the lung. So getting into that a little bit more detail, I did the following. I fixed the alveolar compliance to the value that was found in the model fit. So in other words, if you go back here and you look at the respiratory system elastance, and you assign that entirely to alveolar elastance, if you divide by the number of alveoli in the model, which you know, you can calculate alveolar elastance. So I said, okay, I'm going to fix alveolar elastance and the value is just found. And I'm going to account for the increase in apparent respiratory system elastance through de-recruitment. And the way that was done was by finding the value of a critical radius, R crit here, below which, if I closed any airway that got down to that radius or lower, how did that affect the impedance? So if there's a critical closure radius below which airways close, presumably due to the formation of mucus plugs, liquid bridging across the lumen, can you use that mechanism to account for the increase in elastance? So this is a little bit of a complicated slide, but I'll just give you the bottom line of it. Basically, what I did was I fit that model, that new model with the potential for airway closure to every single one of the subjects. And I said, do any airways close in any of these subjects according to the scheme that I just described? And what I found was that in the lean controls, pre and post asthma, 13% of the subjects had airway closure, 7% after bronchodilation. In the lean asthma, 25% before bronchodilation, 0 afterwards. Obese controls, around 27, 80%. But here was the big signal here. 86% of the obese asthmatics had airways that closed when I did that fitting I just described. And that was reduced to 46% following bronchodilation. So what this means is that those impedances we measured are compatible with the idea that the de-recruitment or the increase in elastance that we saw was caused by closure of small airways rather than intrinsic stiffening of the lung tissue, but actual closure of small airways. And we've had data from so-called asthmatic allergic mice from a couple of decades ago, in which we found the same mechanism. So the conclusions of the study are, first of all, fitting an anatomically based inverse model to impedance is possible, provided you make enough assumptions. And you have to make those assumptions in the interest of reducing the number of free parameters that you can actually get a unique solution to the model fit. The model parameters, by that I mean the diameter of the trachea, the rate at which airways get small as you go into the lung and so forth, they correspond pretty well to actual airway anatomy. It's not like the values that came back were crazy. They were actually pretty accurate. Interestingly, these model fits predict that airway tree dimensions remain essentially unchanged. Either if you look between obese asthmatics versus obese controls, or pre and post bronchodilator. The action again is all in the changes in lung stiffness. And this model predicts, or at least gives fits that are compatible with the idea that the reason why elastance goes up so much in obese asthmatics is because of small airway closure, which again, one would assume is due to liquid bridge formation. In other words, lung de-recruitment by small airway closure. So with that, I will finish and thank you very much for listening and entertain any questions.
Jason, thank you very much. Stop sharing your screen and I'll put the gallery view on and we can open up the floor to some questions. My own comment, because this modeling is way above my pay scale, would there be any signal hidden in the distributions of your data? Because one of the things that struck me is a lot of the parameters you were looking at pre-bronchodilator had a very skewed distribution on your box whiskers, which seemed to normalize to when you gave them bronchodilator. Other than that, I was going to actually draw Jeff into the conversation, both Jeff Max and Fredberg, and I see Zoli has his hand up. So,
sure. Well, I'll just say very quickly. I mean, quite possibly. I mean, these weren't very large patient populations, and basically all we've done here is demonstrate the feasibility of this approach and the fact that it potentially can give you some physiological insights into what may be going on.
Okay. Jeff, I'm going to draw you into the conversation.
Well, I think Jeff Fredberg was first, but okay.
But there's a method to my madness.
There's a method to your madness. Okay. You're mad. Yeah, so this is remarkably similar, although to a study that we did with Swati in asthma, adult asthma, and we had control subjects as well. And we didn't have as many free parameters. So we didn't have the airway ratio parameter going down the lung, but we did do something similar where we assumed that, okay, if this was airway closure or airway narrowing, we had a multi-branch airway tree. So based on a human CT-based model, so not a horse field, but a CT-based model, and found the most interesting thing was that the bronchodilator response in the asthmatics could be almost half of it was explained by airway closure, and a small amount was basically airway closure that was opened by the bronchodilator. The healthy subjects didn't have any airway closure. And all of their bronchodilator response, which they had an appreciable response, could be explained by resistance changes. And the resistance change that we measured in the healthy subjects was exactly the same resistance change when we transferred it to airway diameter that came from the asthmatics. So the asthmatics had the same percent resistance change attributed to airway dilation, homogeneous airway dilation that the healthy subjects had. So in other words, the only difference between asthma and health with a bronchodilator was that the asthmatics had, in addition to bronchodilation, had airway opening, which we thought was remarkable. It didn't matter which generation of the airway tree that we did, which might be related to the fact that airway fraction doesn't seem to matter so much. But the percentage of the airway the lung that was dropped out was the most discerning factor in determining the response, which is apparently what you found, but in obese asthmatics with not exactly the same response that you had in the lean asthmatics. Ours was a little bit stronger, but very much in agreement that reactance is the thing.
Yeah, sure. Look, I mean, I know your work well. In fact, I'll tell everybody, Swati, your PhD student, then became a postdoc with me for a number of years. So I know all about that. Yeah, and look, I'm not telling you that the results, the physiological insights we get from this are any different to anything that's not been known for a while. The thing about this particular model is that it was a formal inverse model. It was formally fit to the data. Whereas what you did was you had a forward model where you simulate things and then you used it as a kind of virtual laboratory in which you played around with various possibilities and found out what worked, which is, you know, a very valuable way to do things.
Right.
This
The one
model I
inverse,
have could
yeah,
be
the one inverse parameter was the number of airways that opened. Yeah. That
Oh,
was
okay.
like,
Yeah, right.
So Jeff Fredberg.
Yeah, Jason, really interesting study, very nice. I have to say three things. I agree, and I have a question. Okay, first, I agree. Back in the 1980s, I published a paper with Jeff Drazen and Roland Ingram. We were looking at dogs, bronchoconstricted dogs using alveolar capsules, and we came to the conclusion that changes of respiratory system resistance or lung resistance were not due to graded narrowing of airways. Rather, they were due to airways dropping out and closing. And we even called that in the paper, we called it quantum mechanics. It had to do with the number of units participating, not how narrow they became. So it totally agrees with what you said.
Yeah.
Second, with regard to obesity, it's been suspected for a long time that obese people have smaller lung volumes and then you'd expect closure. So that also fits.
Yeah.
My question is, when you look at frequency dependence of resistance, like those data you showed, there have been two potential explanations that have been offered. One is shunts and time constant asynchronies and so on. But the other has to do with the hysterosivity parameter in the lung periphery. In your model, I'm curious, for the frequency dependence of resistance that you see, was that attributable to the tissue hysterosivity, or was it had to do with heterogeneity?
Yeah, good question.
Because you can answer that with that model.
Yeah, sure. No, in this model, the hysterosivity was a fixed parameter. So any frequency dependence was due to any parallel heterogeneity as a result of the asymmetry of the airway tree, but most especially because of the serial heterogeneity with the shunt compliance.
No, actually, there actually I don't agree, because even if the hysterosivity is fixed, there'll be frequency dependence of resistance, even with it goes like 1/R. So I'm not sure. I think
I see what you mean.
Yeah.
Sorry, I misinterpreted. Yes, of course. Yeah. There's the inherent frequency dependence because
of the tissue part. So
yeah,
I'm just wondering, you could make the hysterosivity 0 in your model.
Yeah.
So you could take away the tissue contribution and see if the frequency dependence of resistance is still there and attributable to heterogeneity. I'll bet it's not heterogeneity. I'll bet it's all tissue.
I see what you mean. Yeah, you may well be right.
Okay.
All
right. Thank you.
Yeah.
Okay, Zoli, your hand is up. I'll let you turn on your camera and weigh in with your question.
Yes, thank you, Ron. Jason, very nice study, and for me, the major message is that numbers of airways in the periphery may close, and it doesn't appear in the global airway resistance. So one question here: if we had airway resistance measurements by the body box technique, how would it display with peripheral closure and without peripheral closure? Would the airway resistance, the general airway resistance derived from the plethysmographic measurement change or not? But if it does, the most impressive finding is that it is the recruited units don't change the overall resistive properties too much. There's a huge decrease in the L1 surface area, which gives rise to the tissue elastance overall. So again, oscillometry is very sensitive to the changes in reactance, and sometimes the things which you see in the single frequency resistance values are basically negligible.
Yeah, you're absolutely right. I mean, for the reason that Jeff just mentioned, there's got to be some change in, I would think, in plethysmographic resistance, because you have dropout of airways. But the thing is, the airways are arranged in a tree. So if you lose some of them, you can still have a lot of the serial pathways involved in there that make it a significant contribution to resistance. And so it's not going to change that much. But when you get de-recruitment of peripheral lung units, you're going to get elastance changing in inverse direct proportion, which is why it's more sensitive. And I think, this is just another piece of evidence that, let's face it, we all kind of know this now. But the big signal is in reactance. That's why this parameter AX has turned out to be so useful. And it also looks like bronchodilators, for example, will open up airways. And so we think of asthma as a disease involving constriction of airways, but really it looks like it's a disease involving blockage of airways. And maybe the bronchodilators are having an effect on surfactant, for example, which is being suggested, and that's helping to open up airways. So the mechanisms involved are not the same, I would say, as what's classically thought of in often as asthma.
I have a very minor thing on which we have disagreement probably. So my calculations tell me that this is the 7th summer seminar, not the 6th.
Indeed. Your title slide.
Oh, really? Oh, I'm very apologetic. Actually, I know what happened. I took my last year's presentation, modified it, and forgot to change it.
Jason, is
my deep apologies. It is indeed the 7th. Yeah.
It will reflect in your evaluation, but thank you very much. We're going to take one more question from Jules. If your hand is up and you're patiently waiting.
Thanks, Jason. Great talk. Great talk. You had, I just have a question. You had central airway inertance in your model. And I would think that in obesity that chest wall inertance would be important just because of the mass of the wall. Have you looked at adding that to your model, chest wall inertance?
Not specifically. And actually in the anatomic model, the inertance was calculated for every single airway based on the mass of the gas in it. So it is a gas inertance. But when you go and add up all the impedances of the airways in series and parallel, it's including the gas inertance due to its mass in every unit. But no, I haven't added anything due to the mass of the actual chest wall. The reason is because, as far as I'm aware, it seems like the resonant frequency you get around 10 hertz or wherever it is actually due to the mass of the gas in the airways bouncing off the compliance of the respiratory system or the lung. The mass of the tissues starts to come into play when you get resonance effects at around about 80 hertz, around about 100 hertz, about 10 times higher. People who've done acoustic measurements up to 200 hertz have found evidence of that. And you can test this out by putting gases of different densities in the airways and seeing whether the resonances change. And that one doesn't change, which suggests that the mass is not the mass of the gas. So that's why I haven't done it yet.
That makes sense. Thanks.
Okay, I think at this point we are 10 minutes out of sync with the schedule, but I don't want to take from the coffee. So we're going to take a full 20 minutes and come back 10 minutes late for those of you who are following virtually. That take note of that. Sarah, you'll be presenting then instead of at 11:20, 11:30 from McMaster. I'll leave the whole podium up and running. So if people who are online want to network with each other while we're off enjoying a fabulous coffee, you may do so. And we'll see how many of you are left when we come on back. But thank you. Wonderful session, everybody. Okay, everybody, we'll resume. We still another further minute, 5 minutes behind, but not to worry, we'll make up for it at the end. We have a bit of a buffer. It's with great pleasure that I'm going to introduce Azadeh Yodali, who's finally here from the University of Toronto after having attended virtually. So she's going to tie in oscillometry, asthma, and sleep apnea all together. So welcome to the podium, and we are looking forward to your talk, Azadeh.
Good morning, everyone, and thank you so much for having me. I did something that I wasn't planning to do.
What was that?
I think I moved the desk up.
Oh yeah, you can, but you do want to back up.
Yes. I was like, am I having illusions or it's really going down? It's much smarter than what I was expecting to be.
We're not in New York City and we're not in Venice.
Okay, good. So let's see that I'm not making too much mess. Anyways, I'm going to chat, talk, and learn from you about, so share some of the results that we have got over the years, and then try to learn more from you about what can we do next. And it's about the applications of oscillometry to assess a small airway narrowing in people with asthma and sleep apnea. And obviously, I changed my slide right after the last talk. This was supposed to be the last slide, but this is Swati, that she's doing a lot of the work that I'm presenting. And then the other part of the work are by Shay and Nassim. That Shay is now a PhD student. Nassim was a postdoc and now a faculty at Queen's University. And then this last picture that I showed here is for two reasons. The first one is looking at the transition from this baby to this one shows part of the time span of how long did it take us to bring the idea to some of the results. That's the same person. And then the person hiding here is still the Shay that is doing all the work and hopefully continuing this work, and she's there. But what the work is and what we are trying to do. So the project or the hypothesis that my lab is working and continuing to work on is basically about the change in hemodynamics. And part of that is based on the fact that like during the day, because of the gravity, fluid accumulates in the legs. And then when we are lying down to sleep, part of the fluid that was in the leg moves to the upper body and gets to the vascular system. Some of that gets into the pharyngeal airway can narrow the airways in the pharynx and contribute to sleep apnea. And then whether the fluid getting into the thorax and the lungs can contribute to small airway narrowing in asthma. So that's the whole thing that we were looking into. And then how oscillometry can help us to looking at the effects of the fluid. So we did several studies in people with sleep apnea. We developed methods to measure fluid in the legs and then chest and neck. And then we showed that in those with sleep apnea, when they lie down to sleep, actually the leg fluid volume is decreasing, the fluid in the neck is increasing. That increases pharyngeal airway narrowing and worsens the sleep apnea. And then what we focused on was whether a similar thing happens in the thorax and small airways in the lung. And that's one of the works that actually Swati and the other person in the lab have done, that in people with asthma and healthy people, what they did was they were lying down supine, they applied lower body positive pressure with the pens to apply compression, shift fluid out of the legs to the upper body, and then measure the fluid in the leg, in the thorax, and then also airway resistance with oscillometry. And what we found was that here is the data in the healthy population, in those with asthma, and control is when they're just lying down for half an hour almost. And then the intervention is lower body positive pressure. And we looked at the oscillometry and fluid before and after these 30 minutes. And what we found was that in both healthy and asthma group with lower body positive pressure, there was a significant increase in thoracic fluid volume measured with bioimpedance. And then when we looked at the airway resistance with oscillometry, both R5 and X5, only in those with asthma, the lower body positive pressure was associated with a significant increase in R5 and then also X5, suggesting that the airway is narrow. And we also showed that the amount of the change in the resistance with increase was associated with the change in thoracic fluid volume. So the people who got more fluid in their thorax got more airway narrowing with R5. The part that I'm really going to focus on here, and it comes to the association between asthma and the sleep apnea, is whether these two pathways are interacting each other. Is it just that with the lying down during the sleep, just fluid gets to the neck, and that causes airway narrowing in the neck, and then in the thorax, and that increases a small airway narrowing in the lung, or no, there is an interaction. So this was actually the question that we were looking into. And the reason that we wanted to ask that is when we have pharyngeal airway collapse with obstructive sleep apnea, to resume breathing during inspiration, the people are generate more negative intrathoracic pressure. And that extra negative intrathoracic pressure during efforts to resume inspiration is going to pull more blood to the heart and lung, and that may contribute to increased thoracic fluid volume and then potentially airway narrowing. So that's the main question we had, and that's the work of that Karen, the former PhD student, has done. So basically what we did was we used in people while they were awake, we used the Mueller maneuver to simulate obstructive events. So they were basically breathing against their closed mouth and nose, and then generating negative intrathoracic pressure. And what they did was they did 25 Mueller maneuvers with 15 seconds rest in between. And they were watching the negative intrathoracic pressure on the screen through a catheter that went in through the nose into the esophagus, and the goal was to reach to minus 40 centimeters of water. And what we found was that this is the data in patients with asthma, that again, control is just lying supine for half an hour. Mueller maneuver is when they were doing these maneuvers, and compared to the control arm, when they were doing Mueller maneuver, there was a significant increase in thoracic fluid volume. So really by doing the maneuver, fluid got to the thorax. And when we looked at the R5 and X5, the increase in thoracic fluid volume was associated with airway narrowing, both with R5 and X5. And what we found was that this is just a detail in the data, that the changes were significant between the two groups, in the asthma group. We also found that with the doing Mueller maneuver, the R5 also increased in healthy subjects. Now, what we wanted to do was all showing that, yes, when we are looking at the oscillometry, we can track some of the changes in the airway mechanics by increased fluid in the thorax. But we didn't really know what happens, where the fluid is going, what are the real changes that are happening in terms of the elastance, and then how much of that is because of the upper airway or a small airway. So what we did during this Mueller maneuver was we actually put the catheter to the nose. So we put a catheter to the nose with 6 pressure sensors. And so the first one is at the level of esophagus that we control that the people really reach to -40 centimeter of water. There's about 15 centimeter distance between the first and the second one. And these other ones are all each 1 inch apart. And the goal was to see if we can see similar changes that we saw with oscillometry if we look at the pressure from the catheter. And we measured flow at the same time. And so we looked at the pressure, and this is the work that Nassim has done. We looked at the pressure, we looked at the flow, and then we estimated the resistance as the slope. And a lot of that also credit to Jason for the, a lot of guidance that we got from Jason. So the first goal was to see that how much of the data, if we look at the airway resistance and look at the lower and upper airway resistance and total respiratory resistance, how much of that from the catheter sort of correlates or in agreement with the oscillometry. We weren't really sure that how good oscillometry is. My apologies to all the oscillometry people in the room. So that was the first goal, to see that how much these two are in agreement. And it was. So actually what we found was that when we look at the people with asthma, from pre to post Muller maneuver, the resistance increased as we were expected. And the change that we saw in R5 in healthy subjects, we also see that the lower airway resistance increased. The number of participants here are less than what we have with the oscillometry because the data is much noisy when we look at the catheter. So we couldn't get clean data with the catheter. Then we wanted, and that's where we really worked closely with Jason and learned a lot from Jason and what he is doing, that can we now look at the catheter data and see whether we can look into the elastance and elastic pressure and how the fluid may contribute into that. And that's the part that I'm really looking forward to learning from you, because it's like, what does the fluid is doing? And that's the part that we really trying to understand. So we looked to the model that developed by Jason and his group a while ago. And then this is the sample of the data that we have. We have airflow that is reported. This is normal breathing before Muller maneuver. Here is during Muller maneuver that the people stop basically breathing. The pressure goes down. And then we looked at the flow and pressure in between in the breaths that they are not doing Muller maneuver. And we looked at the 5 breaths before starting Muller maneuver and the 5 breaths after 25 Muller maneuvers. And then we try to extract the elastic pressure from this model and then also the elastance. And this is an average of the data that we have from all the subjects. So what we have here is we basically, for just to show how the data looks like, we have 3 groups of subjects. Blue is healthy, black is controlled asthma, and then red is not controlled asthma based on asthma control questionnaire. The vertical axis is the volume or airflow, the volume of the airflow normalized to be able to compare between the groups. And then the horizontal axis is the elastic pressure that they're generating during inspiration. And the data is average for all the subjects. The thick line is post-Muller maneuver, and then the thin line are pre-Muller maneuver. So basically, for example, what it shows is that for a similar volume of airflow generating during inspiration, like at 50% of normalized, if you look at all these subjects or groups, those with not controlled asthma are generating more negative elastic pressure to get to the same amount of the normalized airflow. And the amount of the pressure that they require to generate the flow is increasing from pre-Muller maneuver to post-Muller maneuver. So we're getting more with the Muller maneuver, they're as if they're getting, they need more elastic pressure to generate the same airflow. And this is basically the data averaged among all the subjects in the 3 groups. So again, the dark is pre-Muller maneuver, and then the gray bars are post-Muller, after Muller maneuvers. The vertical, here is the inspiratory elastic pressure. And what we found was that, as I've shown in those with controlled and not controlled asthma, inspiratory elastic pressure was significantly increased after Mueller maneuvers. And then when we looked at the total respiratory elastance, again, it was significantly higher when we looked at the not controlled asthma after Mueller maneuver. We also did a comparison of data between the elastance measured with oscillometry and the catheter-based data, just to see how much agreement we have. This is the Bland-Altman test that it shows that the average or the difference is around -0.2. I mean, it's not perfect because we see that the pattern is linear, so it is more different at the low and high levels. And that is one of the things that we are working on. So to summarize, what we found was that in terms of the physiology, that excessive thoracic fluid volume could increase elastic pressure in people with not controlled asthma. And then the next step, and this was shown with the invasive measurements with the catheter. And then the next step that we could look into is how we can develop other or better analytical methods from the oscillometry to extract these information from the R5 and X5 and the other frequency ranges. And then the other one that is even more important for us is that how we can use these data to better understand the interaction between the narrowing in the upper and pharyngeal and lower airway, and then how to use the data to figure out how the fluid accumulation in the thorax contributes to the lung mechanics in terms of the elastance and elastic pressure. Thank you.
Okay, thank you very much, Silpa. Let me just get over to our gallery view here so we can see everybody in questions. I mean, one of my comments would be, I'm aware of your data and very happy to have been involved with some of this work. So thank you very much for including me. And it certainly was a challenge to get your letter published, but congratulations on doing that. I think you've got a very interesting database that can be mined for some of the, again, with the resistance being nonlinear when it's related to flow, and we're looking at upper airways. Some of the intra-breath methodologies that we're going to be talking about later on in the seminar may have, we could go back and reanalyze your data set with that in mind. And I don't know if Jolie was going to make any comments. I see, Jeff, your hand is up. I don't know if it's Jeff Fredberg. Is your hand up from before or
no? It must be from before. Sorry.
Okay, but I'll give the floor over to Charlie, the man with the great shirt.
Great question.
Fascinating work. Because it's so important, it means what's going on in sleep apnea. I'm a little confused, and it may be just me being dense and I haven't had enough coffee, but you call it elastic pressure. How are you exactly measuring? So you're doing it with a molar catheter in the airway, correct?
Yes, it's similar idea, a bit different from Miller, but yeah, that's a similar thing.
And you're doing it during no period of no airflow.
No, I mean, the data that we looked at is during the breathing before the Mueller maneuver. So it's when we have flow and we have the pressure.
So it's really not static, is it? It's just airway pressure.
Yes.
Okay.
Yes.
That was my confusion. So is it fair to say that on inspiration in these folks with uncontrolled asthma in a horizontal posture, that there's an increase in the amount of pressure being generated per unit of airflow during inspiration?
Yes.
Okay. That's what I wanted to know. That you'll see later in the afternoon. Thanks.
Mechanistically, what do you think might be going on to account for all of this? I think the clinicians are all going to have ideas because we have our preconceived ideas of what asthma does to the lung and the leakiness and the bogginess and how that might change tissue mechanics. And sort of your data kind of fits with that. Maybe the severe asthmatics are having more leak, recruiting more fluid and stiffening the lungs. I wanted to invite anybody else who might have thoughts as to why we are seeing this, or as if you've thought about this, which I'm sure you have.
That's a great question, and that's exactly the part that I wanted to hear more from you of what you're thinking. Because that's, I mean, I have some ideas, but I mean, I'm more here, and that's why I was so passionate to come in person to really hear of what do you think and what's happening and how we can use these data to get more, I mean, like to test or reject some of those hypotheses.
Jeff?
Oh, okay. Yeah, so on mechanism, so it's a fluid shift to the lung. And the fluid shift, we usually think the airways occupy a small fraction of the lung compared to the parenchyma. So the fluid shift should impact the parenchyma, which means it's potentially playing a role in tethering, changing the tethering forces on the small airways. So we're seeing a change in both resistance and reactance. We just heard reactance is more likely involving small airway closures, heterogeneity. I'm not sure that's the case in this population, but maybe it is in the asthmatics probably. But I am confused as to how the tethering of the increasing blood would affect the tethering. I have to think that through, because it would make the parenchyma more stiff. Shouldn't it hold the airways open? No, it's not doing that. That's not what your data are showing. So maybe it is blood in the airways that's actually the predominant effect, even though that there's more blood in the parenchyma. That's my thought on mechanism. But if the Mueller effect is making things worse, should we tell asthmatics to do Valsalvas, the opposite of the Muellers? Get the blood out of there. Like if they're lying down, they have fluid shift in their while they're watching TV or on their watch whatever, lying down in bed. They could either get up, get the blood out into their legs. They could somehow do other maneuvers, but they could do a Valsalva, save them trouble of getting up. Or use CPAP. Or use CPAP.
Yes. So I think that is something that we're looking into to use CPAP, especially it's a sleep study, and we don't think that we can wake them up to do the Valsalva or raise her head. So those are the things that we are thinking of what can be done, or can we do things like controlling the fluid, like with diet, like just a overall body fluid that may help. We are also in line of what Jeff Fredberg is doing. We look into that, whether it can affect the response to deep inspiration that the people, because when you look into what happens during obstructive apnea, usually it ends with a deep inspiration when you have an arousal and then the people are trying to take a deep breath, and whether that mechanism can be affected by just this extra fluid and narrowing of the airways. So that's the other thing that we're looking in terms of the potential mechanism. But it is a question for us. We looked into tethering and I don't know about that one. Sorry, Charlie.
Yeah, so I think it's all liquid in the airway. The reason I think that is that first in animal experiments, we know that's the case. First study ever published, we were infusing dogs with histamine, which opens things up. And you see this incredible increase in the amount of pressure it takes to finally get a volume change. But the experiments I think that are most compelling are the ones I did with David, with the wedge bronchoscope. And you just look down the airways and there's just so much stuff going on. There's liquid, there's mucus. As a recovered asthmatic myself, you can hear it rattling in your chest. You pack it up and then suddenly you breathe better. It's easier to take a breath in. So I think the overwhelming mechanism here is liquid accumulation. It would make sense, and I think that's why your data is so, because the Mueller maneuver, as you point out, would cause more liquid to go in, things get worse, and that makes a lot of sense.
That's a great point, and this is something that we're hoping to do with Sarah and her imaging techniques. To see that really, if we can look into imaging, that where the fluid is going, and it supports that. Thank you.
Thank you, Isabel. Okay, it's with great pleasure. I'm introducing everybody with pleasure, but with particular pleasure that I'm introducing Misha Podavati, who's one of my 4 summer students working with me. And Misha has been working on a project that I think will be of interest to all of us. But please, she's going from first to second year medicine, so be gentle on her. I told her it was a kind audience and that you wouldn't make her regret, but I think she's going to do a bang-up job. And Misha, I'll get your slides ready while you introduce yourself.
Well, the dean is gone, so we can be.
Hi, everyone. Yeah, my name is Misha. I'm a second-year medical student now, and I was working with Ron. He insists, so I'll call him Ron for today. So yeah. No, so you can go here. And just and so I can share this. So you can do a new share. Okay, perfect. So hi, everyone. Like I said, my name is Misha, and today I'm going to be presenting my project looking at the assessment of asthma control, specifically comparing spirometry and spectral oscillometry in asthma patients. Perfect. So just a brief introduction for, although many of you in this room definitely know, spirometry is the most frequently used pulmonary function test. And at the moment, it's used to diagnose and monitor lung diseases, including asthma. Specifically, it assesses lung function during maximal forced expiration through two main parameters. So we have the forced expiratory volume during the first second and the forced vital capacity. But what are the limitations of spirometry? Well, obviously, since this is a maneuver during forced expiration, we have issues with patient cooperation, making sure that they're taking the full inspiration and expiration. We have issues for age and physical limitations. So young children, this is a picture of my brother when he was younger, elderly patients who have trouble taking in the full breath and exhaling to full capacity, and obviously those with neuromuscular or cognitive impairments. And lastly, I'll touch on this later, but the sensitivity for certain lung pathologies. So I guess moving on, in my opinion, the easier, faster, and portable alternative is spectral oscillometry. And why is it so? Is that it's effort independent. We're looking at tidal breathing. It's suitable for neonates to elderly and the cognitively and neuromuscularly impaired. And I won't really touch on the parameters, but these are the ones that I'll be talking about today. I think most of us are very familiar. And for the clinical context, in Canada, asthma is very important. It's the third most common chronic disease that affects approximately 4 million people, and it's characterized by inflammation and narrowing of small airways. Specifically, poorly controlled asthma, which is what I will be talking about, is associated with permanent, irreversible damage to airways and significantly decreased quality of life. So just a brief introduction on our control. So we were looking at the asthma control questionnaire. It was developed by Juniper and colleagues in 1999, and that's how we assessed asthma control in our study. And it looks at a variety of symptoms ranging from nighttime symptoms, limitations of daily activities, and then how often do they use rescue medications, although I know that the guidelines have relatively changed for the last point, and it's similar to the asthma control test. So background on why we do this. We know from previous studies that spirometry is limited in detecting asthma control. And we know from one study that perhaps oscillometry might be a good solution. There was a small cohort of about 60 people in Brazil, led by Chibai and colleagues, and it showed that perhaps intra-breath oscillometry is a better reflection of asthma control. But it focused specifically on intra-breath in severe asthma subjects. So where's the gap? Well, we wanted to find there was a lack of data on real-world, non-severe asthma subjects, and we wanted to reproduce the Brazilian study's results in a new cohort, see if we can. So to see if there's a role of oscillometry in community asthma management. So our question was, can respiratory oscillometry better differentiate between controlled and uncontrolled asthma in the more clinically significant population of non-severe asthma? And our hypothesis was that we thought that both spirometry and oscillometry will separate healthy people from asthma subjects, but only oscillometry will be able to distinguish between uncontrolled and controlled asthma subjects as defined by the ACQ measure of asthma control. So for our method, we did a chart review of approximately 400 of Dr. Danaran's patients. We looked at both asthma and healthy subjects, and we came to a final N of just under 100. To be included, they needed to have for the asthma patients their ACQ scores, their biometrics. We also insisted that their spirometry and oscillometry be within an interval of 6 months and that they needed to have all the full parameters. And so for the healthy control subjects, we based them on normal clinical evaluation, imaging, conventional lung function testing. For asthma, we use a threshold of 10 pack years for smoking history. They needed to show obstructive airway disease on spirometry and either a positive bronchodilator response or positive methylcholine challenge. And we used the established threshold of 1.5 to classify patients as either controlled or uncontrolled. And just briefly on the statistical analysis, we use JASP using Pascual-Wallace or ANOVA as applicable, and we use Python for data visualization. Now moving on to the results. So just to show, we had an N of 28 for healthy, 54 for controlled, and 15 uncontrolled. And across all biometrics, our patient populations were similar across the three groups. So age, sex, height, weight, BMI, and smoking history. And for ACQ, our mean ACQ was 0.5 for controlled and 2.3 for uncontrolled. And this is just a box form plot showing that relatively their ages and BMIs are similar across the board. Now moving on to spirometry. So as you can see here, we looked at FEV1, FVC, the ratio, and MMEF, as well as the percent predicted. And we note that all of them are, for the most part, except for ratio, significant in detecting a difference between the three groups. However, when we look closer at the data, we think that really what's going on is that they're able to detect the difference between healthy and asthma subjects, but they're not able to detect the difference between controlled and uncontrolled. So I'm going to walk you through this. So the first graph, we see FVC, we see significant p-values for controlled and healthy, healthy and uncontrolled, but not for controlled, uncontrolled. And this is similar across the board. The best predictor so far that we've seen is FEV1% predicted but it's still insignificant at detecting a difference between controlled and uncontrolled asthma. And so this is for all spirometry parameters. They could only detect either asthma from healthy, but they can never detect controlled versus uncontrolled. Now, moving on to oscillometry, we can see that once again, they're significant across the board for all parameters at detecting asthma from healthy subjects. Now, what's interesting with oscillometry, however, is that it's also significant at detecting controlled versus uncontrolled asthma. This is across the board for all parameters with the exception of X5. Our significance is between 0.001 and 0.03. So you could see here that for R5 minus 20, or the frequency dependence of resistance and area over the reactance curve, this holds true. Now moving on to some Spearman correlations. So now you can see this is a double annotated heat map. On the top, you'll see the Spearman rho, and on the bottom, you'll see the p-value. We just wanted to show that it's consistent with the literature and that our AX and FEV1 correlation, for example, is around 0.65, 0.7. And then more specifically, we wanted to see how does spirometry correlate with ACQ. And we see a correlation of about 0.2. With the exception of FEV1 predicted, which is at 0.37. And so we wanted to compare and see if oscillometry was just as good as, if not better, at predicting our ACQ. And we could see that the R5 and the AX are just as strong correlations. And many of our other oscillometry parameters are well above the 0.2 and averaging near 0.32 for their correlations. And with that, I'll conclude. So we can note that spirometry distinguishes healthy individuals from those with asthma, but it cannot identify for asthma control. And oscillometry not only differentiates asthma from healthy subjects, but it further discerns controlled and uncontrolled asthma. And these results validate the prior observations we saw in the Brazil study in adults with severe asthma and show that they're applicable to the broader population with non-severe asthma in real-world community practice. And these findings strongly support integrating oscillometry as a practical tool for managing asthma in community healthcare practices. And with that, I'll open it up to questions.
Okay, thank you, Misha. Wonderful talk. And the first person to stay on 10 minutes, perfect. Okay, so I'm going to open up the floor to questions to people here, and I'll get the gallery view going for people who are on the interweb and may have some questions for you. Chung Wei.
Congratulations, Misha, on your work and excellent work. Now, I presume that Ron doesn't leave his asthma patients uncontrolled for very long. And I wonder if you have any longitudinal data within the uncontrolled group where you can do comparisons before and after intervention.
I don't know. It's very possible that we do have this data. We're going to be looking also in the future at whether it predicts exacerbations, because right, you're coming in with maybe someone who's uncontrolled. Does oscillometry stand true to predict the future? And also further, we're trying to see, we have lots of different time points for oscillometry. So we could definitely look at that. I think Dr. Dandaram would agree.
Yeah, no, we obviously these are clinical charts and everything's documented. We just took a cross section. There are a lot of people from industry in the room who are actually eager to hear the answer to that question. Does this device, does that device, does this size molecule, does that size molecule? Can we sort of personalize the medicine using oscillometry to really target the proper therapy, you know, the right drug in the right place at the right time? Again, that is beyond my pay scale in terms of funding, because remember, I'm a full-time clinician. So to go back and do that degree of chart review would be extremely labor intense. I would be open to it, but it's going to be the subject of a grant really that I would need help executing. So I'll put that as something I think that should be done. Whether I can do it between now and next year remains to be seen, but it's a good question.
John. Really nice talk, but I'm going to ask you a question, and that is, and let's assume for this question that Dr. Ron isn't standing there. And next year, when you're in the clinic and you're dealing with patients with asthma, hopefully you'll be going into pulmonology. Would you actually incorporate oscillometry into the assessment? And then how would you balance those data against what the patient's telling and your clinical acumen?
To be honest, I'm completely shocked we don't learn oscillometry in our medical curriculum.
Apparently you're asking that we that they understood spirometry.
Don't get me started about the fact that spirometry is not used. It's the latest study I saw is that the chances of a patient getting spirometry is down around 5% now, where it used to be a coin flip for 50-50. It is not taught very well in the medical schools, if at all, and it is certainly not used by our clinical colleagues out in the wild. And so I think the question I was asking was more nuanced than that, but it was to understand how you might actually incorporate that with your own assessment of the patient, what the patient's telling you, and then you start adding all these lab tests.
You know, it's an interesting question because not specifically for the research I was doing, but there's research that another summer student is working on where we saw a case, and I'm not going to divulge the research, but where oscillometry, a patient will come in, it's specific to COPD, and they will have clearly COPD symptoms. And for example, their oscillometry doesn't correlate. It's a very specific circumstance. And in that case, I think it's always important to look at what's available. So I would look at their spirometry, right? But I think oscillometry, given how easy it is to use, I see patients in the clinic with Dr. Dandaram, they're like, we're so happy we're not doing the like in the, so I think it is a really, I would still look at everything that's available if it's clear to me that their symptoms aren't really getting picked up by oscillometry, because there are cases where that is a possibility.
Full marks.
Yeah. So Charlie, your point is a good one. I mean, spirometry is a great test. It's a robust test that gives us great information. The problem with it is the failure to launch. In other words, as good as it might be, if it's not deployed, it's useless because then we get zero information. And so oscillometry is not the be all and the end all, but it has the leg up of being easy to do. You still nonetheless get results that don't make sense, which will challenge our understanding and our internal models of the disease.
But the failure of spirometry not to be taken into general clinical practice is a clear warning to all of us, and we're the ones who are responsible for that failure could easily happen here.
Well, the dean was here last session. It's too bad he's not here this session, but we certainly will pass on your comments. And I hope that McGill, like Toronto, may be one of the first to integrate this technology into the medical school curriculum. We'll see. David.
That was a wonderful talk. Thank you very much. You did a great job. My question is, knowing that spirometry involves a deep breath and oscillometry doesn't, it might be interesting if you have a sufficient sample size to look at your very mild asthmatic and see if the discriminatory value between controlled and uncontrolled is even better among them, because they would be the ones who, if they take the deep breath of spirometry, it might normalize their spirometry. And maybe you'd find perhaps in a subset that you have even better power to discriminate.
Okay, so you're suggesting looking at those, like by mild asthmatics, you mean non-severe or?
Well, I assume you're non-severe. We're still a large population of asthmatics who are controlled by ACQ. But if you delve a little deeper, you might find that they still have more albuterol use or nocturnal awakenings or something like that. So you could base it on their controller therapy, their GINA score, you know, that kind of thing.
Okay.
And it might be that there's a hidden signal in there that could help show the better performance of oscillometry.
Very cool. I will definitely look into it.
Yeah, the other way that we, with the respiratory effectiveness group, this think tank over in the UK, where we're looking about compliance with therapy, adherence, et cetera, is going into pharmacy records and looking at, say, beta agonists that are dispensed over a period of time, and you get a handle on who is controlled and uncontrolled. Of course, with the GINA guidelines now changing and us taking the duals and using them as needed, so that you're always locking your beta agonist, albeit a long-acting ICS, we're going to lose that way. And in fact, it's a problem with the ACQ that I've adopted in my practice, because going forward, I've changed my practice, which renders my being unable to in future compare the new data with the old data. But I think we all have that same problem in medicine. We just have to change with the times. Okay, well, we are ahead of schedule. Oh, another question.
Sorry. Thank you so much. Fascinating study. I really enjoyed the talk. Quick question. So one of the key barriers when we talk to physicians is about standards, right? So community physicians, they don't have as much of the lung physiology knowledge as we have in this room, obviously. So one of the key questions is, okay, well, you know, obviously oscillometry can be used to separate out the controlled versus uncontrolled, but what standard do I use? Like how? Yes, in the study, comparably with two different groups, you can easily tell there's a difference, but where does that standard lies, right? Like how do we communicate this so that we actually put this into actual practice where someone can say, okay, if you see this percentage of difference, then you know your patient may be uncontrolled. I don't know if this is the right study to address that, or if there may be some kind of a sub data set that in the wealth of the database that could help address that. What are some of them?
I think I know like a bit where you're getting at. I think for COPD, for example, Dr. Danduran was proposing like looking at the AX and saying, okay, above a threshold of this, we're having an issue. Like you can look at also percent difference. So I think that is something that is getting looked at from what I understand. I'm not sure if it's necessarily getting looked at in asthma, but it is an important question, looking at where's the cutoff from someone who's having controlled versus uncontrolled. And I know that this kind of data exists in COPD, for example, where we say an AX of 10, higher, you're having an issue with your COPD, lower, or like also classifying patients. So yes, I think that is important.
Is that something we can do with the data that you have, or is that something that we have to generate?
Well, in the absence of data, clinicians like myself have adopted into our practice, had to make some arbitrary temporary decisions. And happily and independently, Brian Lipworth and myself have come to the same conclusion for frequency dependence of resistance and reactance area in the setting of COPD. But the person really to address your question is sitting immediately behind you, because David is our fearless leader, helping us weave our way through this murky and evolving literature to come out at the end with some kind of consensus to guide practice. But it's really in evolution, which makes this whole field a lot of fun, as well as challenging. Oh, is there somebody on? Who am I missing here? Oh, okay. Ihan, how are you? Welcome back.
Yeah. Thank you for the great presentation. I have a question regarding the change after the bronchodilator. Did you use the change of oscillometry data after the bronchodilator test to see if they could use to differentiate the asthma control? Because Sorry, because we have some data showing that if the asthma patient had a greater reduction in AX, they might have a great chance to have type 2 inflammation, including atopy, IgE level, blood eosinophil. So I think you might be interested to see the change after the bronchodilator to see if they can differentiate the asthma control level.
So I don't believe we looked at that, but it's an interesting direction to take to see if they may be able to change post-bronchodilator to see if oscillometry would catch whether they're inflammatory asthma or not. Is that what you suggested?
Yeah.
But we did not.
Okay. Thank you.
Yeah, no, the sad reality is that we're 3 respirologists for 350,000 people. So the clinic is really rock and roll. And so I'm doing pre-bronchodilator only in order to get through the volume of patients that we see in any given day. In the ideal world, we would have that data. So I throw the challenge back to the people in the audience, both here and virtually. If you're in a situation that allows you to do that, please gather that data and share it with us. I think you raised an excellent question. I'm going to take one last question from Chia Jun Chun, who happily spent a couple of weeks with me. He's from the Singapore General Hospital. Great to see you. And you also spent some time with the University of Toronto group. So welcome, and let's hear your question.
No, not any question, but just to add on to what the other doctor was saying, is that back in Singapore, we look at the patient's exhaled nitric oxide level to sort of ascertain whether is the asthma out of control or whether is it getting better. So that's one of the ways back home here that we use to assess for patients with severe asthma. Yeah, so every time when they come in for a visit, they'll do an exhaled nitric oxide, and if the levels are dropping, then we know it's under control. But if it's not, then either patient's not compliant or it's not working for them. Yeah.
Yeah, Jun Chun, I think that's a great point, because I use oscillometry and I'll challenge patients by saying, you haven't been taking your medications, have you? And then they admit, because you see such a dramatic change in the AX and the frequency dependence of resistance, which were the two parameters where I like to sort of place my bet when I'm evaluating patients. So thanks for bringing that point up. Yeah. I think at this point, we're going to move on. Misha, thank you very much for a job well done. And hopefully we'll see Misha back next year. But in the meantime, we're going to go to McMaster University down the 401 and just past Toronto, where Sarah should be ready to talk about the effects of the biologics and how we might be evaluating with oscillometry. Sarah, let me stop sharing here and you can start sharing. Oh, you are viewing. Okay, so let me just get out of this view and you should be good to go then. Great, take it away, Sarah.
Great, you should be able to see my screen there.
We do.
Okay, perfect. So thanks, Ron, for that kind introduction, and thanks again for putting together another excellent seminar program. It's an absolute pleasure to have this opportunity to present some data to this group from a small clinical trial that Param Nair and our team recently completed at McMaster University and the Firestone Institute for Respiratory Health. And in this trial, we evaluated the effect of dupilumab on oscillometry measurements in patients with moderate to severe asthma. So dupilumab is a monoclonal antibody that targets the IL-4 receptor alpha and blocks signaling of both IL-4 and IL-13. And it's been shown to improve asthma outcomes in numerous phase 3 clinical trials. And the clinical benefit of this IL-4 alpha antagonism by dupilumab are likely due to the reduction in characteristic features of IL-4 and IL-13 signaling. And if you look at this figure here, you can see that some of these features include airway smooth muscle contractility, airway remodeling, mucus production, and recruitment of eosinophils into the airway. However, there's really no published evidence to support this mechanism of clinical benefit in patients with asthma. So the primary objective of this trial was to evaluate the effects of dupilumab on airway mucus and airway remodeling assessed by CT, and then their functional consequence on ventilation assessed by xenon MRI in patients with moderate to severe asthma. And in addition to this, an exploratory objective of this trial is to evaluate the effects of dupilumab on resistance and reactance measured by oscillometry. So this exploratory objective will be the focus of my talk, but I'll also provide some additional CT and MRI results for context and to provide some mechanistic insight into dupilumab treatment response and what these changes in oscillometry with this treatment may mean. So brief introduction into the study design. It was a single center, randomized, double-blind, placebo-controlled trial. We evaluated adults with uncontrolled moderate to severe asthma. They had to have current airway hyperresponsiveness and also a current type 2 immune signature. So some evidence of eosinophilic inflammation. The study duration was 22 weeks, but the treatment period was 16 weeks. So during that treatment period, patients were randomly assigned at a 1-to-1 ratio to receive dupilumab or matching placebo every 2 weeks. And outcomes were evaluated as the change from baseline or week 0 to end of treatment at week 16. So 48 patients were screened for study eligibility, and 25 were ultimately randomized. 13 patients in the dupilumab group and 11 in the placebo group ended up completing their endpoint assessment visits and were included in the efficacy analysis that I'll present to you today. And all patients completed oscillometry using the Therasis Tremoflow device. They underwent hyperpolarized xenon MRI and chest CT. And this was performed at week 0 and then at week 16 or end of treatment. Shown here is the baseline demographics and clinical characteristics for both treatment groups. Overall, the groups were relatively well balanced, although the placebo group did report a worse asthma control and worse asthma-related quality of life, indicated by a higher ACQ-5 and a lower AQ-LQ, respectively. And if we focus in on the oscillometry measurements, there was actually a trend towards worse or increased oscillometry measurements in the dupilumab group compared to the placebo group. But this difference only reached statistical significance for our R19. Okay, so for context, the key outcomes that we assessed in this study towards our primary objective were mucus plugging assessed by the CT mucus score, airway remodeling assessed by the CT wall area percentage, and ventilation defects assessed by xenon MRI VDP. So I'll walk you through these outcomes quickly here. Shown here in the first panel is the change in the CT mucus score for patients treated with dupilumab and placebo. The dupilumab group is shown in maroon, placebo group in gray. And the CT mucus score was significantly reduced with dupilumab, and this reduction was greater than placebo. And for those of you who aren't familiar with this mucus score, I'm summarizing or showing a few examples here of representative airways, visualizing mucus plugs at baseline that were cleared following 16 weeks of dupilumab. So this CT mucus score essentially quantifies these mucus plugs within the airways that are visualized on CT. And in order to be considered towards the score, this occlusion must be a complete occlusion of the airway lumen. And that'll be important for some of the results I present to you later. The middle panel here summarizes the effect of dupilumab in comparison with placebo on airway remodeling. So we observed that the CT wall area percent was significantly decreased with dupilumab, and this decrease was greater when compared to placebo. Finally, the xenon MRI ventilation defect percent, similar to the other outcomes, the ventilation defect percent was decreased, so there was an improvement in ventilation following dupilumab, and this improvement was greater than placebo. And this figure below shows representative ventilation scans for 2 patients acquired at baseline and after 16 weeks of dupilumab. And for those of you not used to looking at these images, the ventilated lung is shown here in cyan, and these regions or black regions of signal void within the thoracic cavity are ventilation defects. And you can see here, these yellow arrows are highlighting defect regions at baseline that were ventilated following dupilumab. Okay, so dupilumab, we observed that dupilumab reduced CT biomarkers of airway mucus and airway remodeling, and this consequently improved ventilation assessed by MRI. So we then asked the question, what was or what is the consequence of this on respiratory system resistance and reactance assessed by oscillometry? So shown here is the week 0 and week 16 respiratory resistance measurements for patients in this trial. The plots are organized similar to the ones that I previously walked you through. And what we observed was that the resistance at 5 hertz and the frequency dependence of resistance, so R5 minus R19, was significantly reduced after dupilumab, and this reduction was greater than our placebo group. The change in resistance at 19 hertz, however, wasn't different between the treatment groups. And here's the data from reactance at 5 hertz, and then the area of low frequency reactance, or AX. And we observed that the magnitude of improvement in both X5 and AX were significantly greater with dupilumab than placebo. Okay, so improvements in oscillometry measurements of R5, R5 minus 19, X5, and AX were all greater with dupilumab than placebo, together suggesting that dupilumab improves small airways dysfunction in patients with moderate to severe asthma. But what about mechanistic relationships? Were these changes in oscillometry associated with mucus plugging, complete occlusion of the airway lumen by mucus, by airway remodeling, or ventilation defects assessed by MRI? And this is just a representative patient here that I'll show over the next few slides, their baseline data and their post-dupilumab data. As I highlighted earlier, you can see this large ventilation defect at baseline. This was spatially correlated to an occluded segmental airway plugged by mucus in the right upper lobe. The corresponding oscillometry measurements for this patient, and then their post-dupilumab data. We see, resolution of that ventilation defect, and that was associated with the clearing of that mucus plug and increased patency of the airway lumen for this patient. And corresponding to that, we saw improved oscillometry. So now considering all of those patients who were treated with dupilumab, shown here are relationships of baseline mucus burden with the post-dupilumab change in oscillometry measurements. So the CT mucus score is shown here on the x-axis of these plots. And again, a higher mucus score indicates a greater burden of mucus. And what we observed was that a higher mucus burden at baseline, so prior to treatment, was associated with a greater post-dupilumab improvement in R5, in X5, and in AX. And we also observed that there was a greater reduction, that a greater reduction in mucus plugging was associated with a greater improvement in R5. So that significant relationship is shown here. And I think this is interesting as it suggests that, R5 is sensitive to changes in airway obstruction due to the movement of mucus plugging in response to this treatment. And I don't want to, mitigate these other relationships as relationships with R5 minus 19 and X5 and AX. We're all really on the threshold of statistical significance. I didn't have time to put a slide together for this, but I did want to highlight very briefly that similar mechanistic relationships were not observed for CT wall area percent. However, I don't think we should negate them at this point due to the small size of this trial. And I also wanted to highlight that there was, we also didn't observe any significant relationships with patient-reported outcomes and improvement in patient-reported outcomes following dupilumab with any of the oscillometry measurements. So I thought I would highlight that since it's been the topic of discussion for many of the previous talks. But we also investigated relationships between the post-dupilumab change in ventilation assessed by xenon MRI and the change in oscillometry measurements. And we observed that improved ventilation quantified by xenon BDP correlated with an improved X5. And again, these other relationships with R5 minus 19 and AX were really near statistical significance as well. And this cyan data point on the plots corresponds to the case I'm showing above, who I already detailed, that had this large ventilation defects at baseline that were resolved post dupilumab. So my interpretation of this is that there's increased airway patency and increased communicating lung volume post dupilumab that we can nicely visualize with MRI, and this is consistent with these observed changes in oscillometry measurements. Okay, to conclude, this trial provides the first evidence of the mechanism of clinical improvement with dupilumab in patients with moderate to severe asthma by demonstrating that dupilumab reduces airway mucus plugging and airway remodeling. And this is certainly consistent with what we would expect based on the mechanism of action of the drug and IL-4 and IL-13 biology. Now, the functional consequence of this on improved airflow was confirmed by improved ventilation quantified by xenon MRI. But while the improvement in ventilation observed by MRI may reflect both large and small airways obstruction, with this reduction in R5 minus 19, X5, and AX observed by oscillometry, this provides us with some confidence, or does indeed suggest, that dupilumab also improves small airway function. And we were able to demonstrate this, we were able to demonstrate a significant effect in a relatively small study, which was quite impressive. And for patients who were treated with dupilumab, we observed that higher mucus burden at baseline was associated with greater improvements in R5, X5, and AX. And we also observed that a greater reduction in mucus plugging following dupilumab was associated with greater improvements in R5. So we think these relationships are quite important and clinically relevant, as they implicate mucus plugging as a relevant mechanism by which dupilumab improves respiratory system resistance and reactance. I will end there by thanking the team that was involved in this trial, acknowledging our sources of funding. Thanks very much, and I'd be happy to answer any questions.
Sarah, that was wonderful. As you know, and I'll tell the audience, I'm a big fan of your work, of Grace Paraga's work, and of Rachel Eddy's work. I think these images that you generate to allow us mere clinicians to understand what's going on are invaluable. My own general practitioners in my community understand what ventilatory heterogeneity is, thanks to the images that you guys have been generating. So just a call out on that. I'm sure there's a bunch of questions here, and so I'll take some questions from the live audience here before we go to the virtual audience as I get the gallery view up. Charlie.
Really nice study. Well done and nicely presented. I'm wondering about the conclusion that the image changes one sees on CT are actually due to mucus. And as opposed to just liquid bridging and accumulation of liquid and cell debris within the airway lumen, as opposed to sticky mucus, which is a very different kind of thing. Or is this just the nature of the field at the moment?
Yeah, so thanks. That's a really good point. And you know, the short answer to that is that we have not confirmed that those occlusions are indeed mucus. The mucin content in those plugs is uncertain at this point. So, you know, at this point, the better description probably is intraluminal occlusion. As you mentioned, it could be, you know, cells, debris, various things. And your point there on, yeah, so I completely agree with that. We can just say there's clearance of complete luminal occlusion, and that is spatially correlated with improved ventilation. I'm collaborating with an immunologist, Dr. Manali Mukherjee, who's we're currently going in and image guiding bronchoscopy to these plugs to take them out and then examine their cellular contents. And I think in reality, the contents is probably going to be quite heterogeneous across patients with asthma. So that's to come.
Yeah, that's our experience too, just looking through the scope. It's a mixed bag of that. And you really don't see that amount of mucus as you would guess until you get into the really severe one.
Yihan, you've had experience with biologics and oscillometry.
Yeah.
What are your comments?
Yeah, thank you, Ron. I'm so excited to see this data and great presentation, Sarah. And yeah, because as in my presentation, we don't have. It is a shame we don't have many patients who receive dupilumab therapy, and we don't see that significant improvement in either impulsive oscillometry or spirometry in patients who receive omalizumab or anti-IL-5 therapy. So did you compare your result with other biologics, or do you think that is that the unique mechanism of dupilumab targeting IL-5, IL-4, IL-13 pathway to see this difference?
Yeah, so that's a good question. So we haven't directly compared the response of oscillometry from dupilumab to other biologics. We do have that data. We just haven't got around to analyzing it. So we're certainly eager to look into that. And we're also we're about halfway through a clinical trial with the same study design and the same endpoints, looking at tezepelumab, which is more upstream. Target. So we'll be able to kind of do a head-to-head comparison between those two drugs, and then we do acquire the data clinically. So we just need to get to that for sure. And then I guess there does seem to be some inconsistency in the data regarding response to oscillometry responsiveness to benralizumab. I know there's some published data that suggests there really isn't any change in response to benralizumab, which we know completely wipes out the eosinophils from the lung. So I think this might come down to mechanisms and what's driving the the pathology in the airway, and maybe eosinophils don't have as large of an impact on these oscillometry measurements as other components.
Great, thank you.
Sandeep, and then we'll go to the live audience. What are your thoughts?
Thank you, Sarah. That was an absolutely brilliant presentation. Even a small sample size was able to show a good signal on oscillometry. I think this is very exciting. You did not show the spirometry data. I'm assuming that the spirometry did not show anything. Is that correct?
No, so yes, so I didn't include the spirometry data, but just to briefly summarize, actually, I did have a slide. I should just pull it up on my end to remind myself so I don't misquote here. But oh yes, okay, so there was a significant between group effect also with FEV1. So dupilumab actually has shown, quite compelling improvements in FEV1. So we were able to show a between group effect even with FEV1. I don't have the FVC data in front of me here, so I don't want to comment on that.
Good, thank you.
Thanks very much.
You got a question?
Yes, that was very convincing. Congratulations. And I just want to say it's more common than the question that I think we shoot ourselves in the foot when we look at the response to treatment with oscillometry, because all these oscillometric readouts are volume dependent, and sometimes the beneficial effect of the treatment it's just lung deflation, and the patients are hyperinflated and suddenly they feel better because of the drugs and they deflated. But this deflation will worsen all these oscillometry readouts. So when you look at the changes in MRI, for example, in the change in reactants, that were already significant. But I think without this confounding factor, it would be even stronger.
Mm-hmm.
I think that's a good point you raised as well, because remember, I think, Sarah, and correct me if you're wrong, your technique, you take, is it 1 FRC plus 1 liter for the inhalation of acquisition? So you're operating at a higher lung volume when you get your MRI data than we would be when you're acquiring your oscillometry data.
Yeah, so we acquired the MRI at FRC plus 1 liter. That's correct. Yeah.
Jeff.
Very nice, Sarah. I'm curious about the slight difference in findings between R5, the most sensitive measure you have, and R5 minus 19 and X5, which, this audience or we predicate those measures as being responsible for small airways or sensitive to small airways, but there's other factors that can contribute them. But one of the things that we predicate R5 minus 19 to be a good measure of small airways is that the resistance at 19 hertz is already plateaued and it's at its flat. But when you're dealing with very severe asthmatics, that may not necessarily be the case. So your R5 minus 19 is not separating out what we think is the central airways completely in the most severe patients, which means that you're still getting a mixture with that measure. I wonder if some of your severe asthmatics, it wasn't plateaued at R19.
Yeah, and to be honest, that's a really good point, Jeff. And I think, I didn't really emphasize this much, but there was a lot of heterogeneity, interpatient heterogeneity in this data. And I think it's really worth, going back and having a look at that to answer questions just like that. So I haven't looked at that in too much detail. That's likely the case based on just, looking at a few of these cases that were, I've discussed with some of our clinical colleagues. But I think it's worth a deep dive into this data to look at things like that. And we just haven't done that yet.
Okay, I'll wrap this discussion up to see if any of our industry members want to have a comment. You guys have a tremendous interest, obviously, in where biologics are going to go. How do you see this oscillometry as fitting in with your evaluation of biologics? Well,
no, please go ahead.
I'm less on the biologics, but I don't know what's the baseline of other therapies that those patients are using. Like, are they on triple therapy or dual therapy?
Yeah, so all of these patients, they were moderate to severe asthmatics, mostly severe. So I don't know if they were necessarily on, one of these new triple inhaler devices, but they were all on a high dose ICS. Some of them were also on maintenance prednisone. Most of them had been previously on biologics and had failed biologics. So this is kind of on your far end of the spectrum of quite severe asthma.
Good. Well, thanks, Sarah. It was great.
Thanks very much.
So don't worry about the time. We're going to finish up with Patrick Donahue, who's from the University of Rochester. So we're meeting for only the second time. The first time was ATS. So welcome, Patrick. You take the full 20 minutes for your talk, and we've time shifted the afternoon. So we'll be back here at 1:15. And I've already emailed the first two virtual presenters of the afternoon, so they're aware of that. So don't feel rushed, even though you're the only thing between us and lunch.
Pressure here, right?
No pressure at all. I'm not hungry.
Everybody can see and hear me, okay? Yeah, so I'm Patrick. I'm from the University of Rochester in the US. And it's my great pleasure to be here. Thanks, Ron. Great discussion on my poster at ETS, and it's truly a privilege to be here. I'm kind of in the in-between. I just finished fellowship training at the University of Rochester in pulmonary and critical care medicine. And I'm starting as junior faculty there later this summer. So I'm just kind of in that no man's land in between. And I'm really happy to talk to you about our small study in oscillometry and asthma, as well as inducible laryngeal obstruction. For those of you who are unfamiliar with that term, ILO, it's just a rebranded vocal cord dysfunction. So we committed to that terminology at the beginning of the study, and as we've talked about the results, it led to a little bit of confusion. So apologies in advance for that. Just vocal cord dysfunction, that's what we're talking about. I have no disclosures, no one's paying me to do this. So some background. So as many of you in this room know, there's been many experimental models over the years looking at what happens with dynamic upper airway collapse and oscillometry. There's also been several smaller clinical studies looking at what happens in real patients. So here's one example of a study in ILO/VCP patients that showed an increase in the standard deviation of impedance at 5 Hertz. And as you see in this graph, the y-axis is that standard deviation, these huge fluctuations in impedance. That was remarkably different in these patients with laryngoscopy-proven ILO or vocal cord dysfunction compared to patients with asthma. So huge swings in impedance is one thing to look for. It's also been described, and I'll just highlight this one case report of a patient, single patient with severe asthma, biologic, but also concomitant ILO, where these authors describe these inspiratory RRS spikes that was seen in this one particular patient. So just it's kind of a complicated graph here, but really it's just y-axis being resistance, the z-axis here being the range of frequencies, and the x-axis being time. Rather than having that fall in resistance we would expect from the airway caliber increasing during inspiration, you see these like jagged spikes here. So what they described is after speech therapy, we get these nice valleys during inspiration that we would expect. So this was potentially a marker of upper airway collapse, ILO, and generated our interest. And just full disclosure too, at University of Rochester, and myself and my mentors were relatively new to oscillometry. So we were looking for a cool project to do as we started to incorporate this clinically. So based on what we could collect from the literature, it's unknown if routine oscillometry can reliably detect ILO. And again, this is from the vantage point of a clinician. Like experimentally, we can, go look at the vocal cords and measure oscillometry. But realistically, if you're in the clinic getting routine oscillometry based on standard technical guidelines, could we reliably detect ILO? What's the sensitivity and specificity for this? So we conducted this very small single center observational study. I really want to emphasize the real world nature of this. We used the oscillometer that we purchased, which is the Tremoflow C100. We identified 3 pre-specified groups. So a healthy cohort, some patients with asthma from our severe asthma clinic, as well as patients with VCD or ILO. We partnered up with some laryngology colleagues who had some of these patients. And our hypothesis was, could routine oscillometry, so just if you happen to be getting oscillometry in a patient in your clinic, not doing any triggering maneuvers, just happen to get it, can we detect this high resistance variability or these inspiratory spikes in ILO compared to asthma, especially because now we have the neuro oscillometers that have all this intra-breath analysis. So we were hopeful to see maybe a small signal that could differentiate these patients. I've selected some, we collected a lot of baseline information, but I just highlighted a few to share. Age was a similar large range between the two groups, and female predominance was unsurprising. Things that were a little important to note, just happenstance, our asthma group tended to be a little bit heavier than the ILO group, as judged by the BMI. It's also a little interesting to me was the ILO group still had a significant percentage of patients who were being treated with inhalers and actually gotten steroid bursts within the past year. Now, to me, that could mean one or two things. Number one, we were terrible at binning these patients into the appropriate groups. But the second thing, I think for any of the clinicians in the room probably realize that this patient population is very frustrating to deal with. And someone along the line probably potentially inappropriately provided these patients with inhalers or steroids. So I think either of those are possible. Other little things to note, the overall, this is all per bronchodilator spirometry for our asthma and ILO patients that were done relatively recent prior to the oscillometry measure. They were slightly decreased compared to the ILO, not super significantly, but just something to note. So getting right into what our oscillometry measures demonstrated. Looked at a bunch of exploratory variables that were offered through the TremoFlow software. First off, interested in this huge swings of resistance. We did not observe that in our ILO group compared to the asthmatics. Again, these are non-triggered patients. So as you can see here, pretty much a spread of data across the asthmatics. For this, we chose the difference between the max R5 and R5 min kind of arbitrarily, as well as the standard deviation of R5. And really, there wasn't a signal here that the ILO group was trending higher. We also looked at some of the intra-breath measures as well, several. This is just a highlight of a few that really also did not show a dramatic difference in the ILO group compared to the asthma. Again, y-axis here is our different resistance measures. We have different subgroups here, control, asthma, and ILO. Really not significant. And if anything, the asthma group trended a little higher than the ILO group. Unsurprisingly, for other variables that are we're all very familiar with, the asthma patients look like asthma. You know, big whoop, right? Not a huge surprise here. R5, R20, AX, and X5 all pretty significantly different. Your eye might glance to this one outlier here. Unlike the intra-breath measures, the groupings were pretty tight for the control and the ILO group, and then we have this one outlier here. Looking into that one subject's case a little closer, asthma had been ruled out many years ago, and this particular patient had no recent spirometry methylcholine challenge, and our hunch, and was still, as you look at her chart, was getting speech therapy over and over again, still having symptoms. So my hunch is that the patient truly has asthma and probably was not binned correctly by our assessment. I'm not going to spend too much time on this, but just kind of tying this in, interestingly, to what's been already talked about is if we stratify the asthma group by ACT score, the patients who were poorly controlled, unsurprisingly, had the small airways parameters of R20, AX, and X5 were significantly different. Again, not a huge surprise to anyone in this room. So that's what we have so far with this study, and I'll just highlight some summary points. Limitations are, by design, we did not trigger these patients. Again, from a very clinician kind of focused point of view, we are just interested in, could there be a subtle signal in the intra-breath analysis that could tip us off? That didn't really pan out so far in our data. And another limitation was we did not bring these patients in and do laryngoscopy, spirometry, oscillometry on the same day, which would be ideal. But again, very practical real-world design. So my conclusions are, this, in our particular cohort, it's suggestive that oscillometry it could not detect variables specific to ILO, and that our small airways parameters, our asthma patients look like asthma, and the uncontrolled asthmatics look like uncontrolled asthma. So no big surprise there. For future directions, I think there's a role for oscillometry in ILO and BCD, and I'm more interested in whether there's a practical way that a clinician can elicit some maneuvers or triggering in the clinic, even just some basic breathing maneuvers that can maybe tip off some of these intra-breath variables. It'd be nice not to have a treadmill in your office and have a patient run on the treadmill to get these findings that have been shown in other studies. So I think that's going to be the next step. So just end with special thanks to the team that helped to make this happen, notably my mentors, Steve Joris and Sandy Corona. Appreciate your time.
Doctor, thank you very much. I think this is exciting work and really is long overdue. But first of all, you hail from the home of oscillometry. As you probably know, that Arthur Dubois conceived of these things, and as Charlie elegantly told us a few seminars ago when he gave the Life and Times of Arthur Dubois, this is where he did his first work in oscillometry before migrating over to UPenn. Secondly, as a clinician, these are indeed challenging. I think you can have both. I have patients where I'm convinced that they have asthma as an exacerbation into the hospital, and then I see them on day 4 and day 5, and they're still wheezing, but it's more upper here. And, you know, we look at oscillometry, it looks like the more distal stuff is okay, and the RTs from Lakeshore General are happily over there with me, and they can confirm this is what we're seeing, but they're anecdotes. We don't have enough to be conclusive. And what's exciting about your work is you're actually organizing it, and numbers may be able to define more what's going on. So those were my comments. I'm sure there's going to be others from the audience, especially from industry, because upper airway is becoming very, very looked at now that there may be some pharmacologic agents that might be acting at that locale. We'll let them speak up on that. And also with the intra-breath technology, which I think will be very fruitful. I'm presuming that your stuff is averaging the inspiratory and the expiratory, and you're not actually looking at zero flow points.
No, yeah, well, I actually, based on your suggestion, I actually did graph the resistance. I didn't share that data with you guys just for time, but yeah, looking at resistance charted against flow, plotted against flow, pressure, and volume, and even at where flow reaches 0, it really, and again, I didn't do any statistical analysis, just kind of eyeballed it, and there wasn't really a signal that I could see for the ILO group versus the asthma group.
Okay. Well, we'll come back on that based on the stuff that's going to be done tomorrow afternoon. I think that'll be fruitful, both lunch coming up now and supper tonight for people to share their thoughts. Charlie, you had some thoughts to share too.
Yeah, so full disclosure, I spent 18 years at Jewish during the period of time it was originally described, and was running the lung function lab there. So I've seen a lot of these. And I'm glad that you've gotten away from this other crazy term and talk about what it really is, which is the vocal cords misbehaving. So I take it that you selected patients that our ENT colleagues told you had BCD based on laryngoscopy and going through a bunch of different maneuvers that they put these folks through. Is that correct?
Yeah, so yeah, I didn't go into this in the baseline characteristics, but yeah, these were patients where there's a consensus they had ILO,
right?
But only about 8 of them had truly laryngoscopy proven ILO as they went through the full Monty. There was 6, or I say 5 of them that failed. Basically, asthma had been ruled out at some point during their workup. ENT had done the rigmarole, and at the end of it, we all kind of decided that clinically, due to Pittsburgh BCD index being high, maybe one of them had like flattening of the spirometry, but never had positive laryngoscopy. So it just shows you how nebulous this diagnosis is.
It's very nebulous.
So nebulous, yeah.
Every time I get asked you to talk about it, I look up, has any consensus gotten together to decide how you actually diagnose this? Or I call one of my fellows, Sue Brugman, and ask her if there's anything new there, and she says no. So I think that's the key takeaway, is that this group of patients is very elusive. Now, in terms of inducing it, I can give you several suggestions. The one that we used to use all the time that really worked like gangbusters was inhaling histamine, which not a single IRB countries anymore anyway. Another possibility is metabisulfide. So if you put it in a like lemonade, it'll acidify it and it produces actually SO2. But I've never tested it. So that would be my first guess. It's something that is going to cause irritation and get these cords or just stress. Exercise, as you point out, is a little trickier to do with a it's big rare ball. So something else would be better.
I'll just piggyback on your comment too, that even between laryngologists, the positive laryngoscopy is very subjective too. So I find that as I've embarked on this project to be one of the big challenges is the gold standard is very subjective.
Oh boy, is it ever.
I was just going to say, I see PCD every single day. And I'll tell you how many people were given a diagnosis in the military of asthma without spirometry or anything or symptoms. There's like a retrospective review where people were, kind of taken out of theater because of vocal cord dysfunction and had direct laryngoscopy. So that's been part of our actual workup. Like as patients come in, we look for people with, upper airway disease, like sinus disease, vocal cord dysfunction, asthma, and, kind of distal lung disease. I can't tell you how many people have asthma and vocal cord dysfunction. I think we've actually published on it in the Journal of Occupational Environmental Medicine in this patient population. So I think it's helpful to know that just because, you just keep getting these crazy ACT scores and you're like, it's not their asthma, it's, it's their vocal cord dysfunction. And we've struggled kind of with the diagnosis. I have not felt like I've had like in partnering with ENT, they often defer to us on the vocal cord dysfunction. In part, I think just because we put in a little bit of time to do direct laryngoscopy and video laryngoscopy. If you take like the glide scope, tiny little disposable bronchoscopes or laryngoscopes that they have, you can video record this because I've done probably last year, I did 100 methacholine challenges paired with laryngoscopies to try to trigger symptoms. That, as you mentioned, like that doesn't work for everybody. We've even done continuous video laryngoscopy with exercise. Well, at National Jewish Health, there's somebody very interested in exercise-induced, or like ILO or whatever. So I think knowing what their triggers are and trying to re-trigger that symptom. I never just do a basic laryngoscopy on anyone unless I know they are literally symptomatic all the time, like, hoarseness and everything. Your just yield is not going to be great. So I would, as you're developing this partnership with like ENT, you need to offer there and thinking about the video piece where you can go back and look at it and grade it may also help with that and seeing how people are assessing that. But I can talk to you offline about it.
I'd love to.
And I have a lot of.
Yeah.
Okay, well, for no questions online, I think we'll adjourn for lunch. We'll be back here in 55 minutes at 1:15 for Raymond's talk and Disha's talk. So enjoy lunch. It should be if things have unfolded as planned up on the 6th floor where you had coffee. Thank you.
So much for the actually.